a God-fearing country, and our motto says, "For God and my country." Please, Kenneth, can you do the needful? Thank you.
Good morning, delegates. May I request that we stand up for this prayer? So let us pray. Almighty and everlasting Father, we thank you so much for the gift of the new day. We thank you for the opportunity to meet and reflect on the work we have done, but also learn and be able to take away innovations on how we can do better in health service delivery, on how we can improve our systems. Father, we pray for journey mercies for those who are coming in. We pray for wisdom and guidance and direction throughout the activities. We pray for safety and protection, and we pray for excellence in whatever we are going to do. We pray all this through Jesus Christ our Lord. Amen.
Thank you so much, Kenneth, for that prayer. Ladies and gentlemen, once again, you are most welcome. Now the business is about to begin. Please, let's settle in. And with time, the different dignitaries here present will be recognized accordingly, because as they come in, and they will be warmly welcomed at that moment in time. The names are Tabuleba Chaita Basajja Tebadiba. I'll be helping out with this program directing, and with my colleague Michael, who is somewhere. You'll be hearing his voice very soon. And for me, I'm delighted because we are on the 10th annual conference, and at least I've been part of this conference since inception, when they began, at least from the first one. So we are excited. So allow me at this moment and time to invite our director, Dr. Joseph Okwale, to come over. He will usher in the presenters, and please to take over the next session. Dr. Okwale, Joseph Okwale. Just a moment. You know, big is big. And like I was saying, we are going to have these two presentations, and I'm requesting, it's my humble request to Dr. Martin Sendiona, the Acting Commissioner of Health Services in charge of SCAP, to come and chair this session of these two presentations, and he will be the one to invite the presenters and handle the discussion thereafter. Over to you, Dr. Martin. The seats are here, and you will do the needful. Thank you, and a good morning to all of you, and a welcome to those who have just joined us. Thank you.
Yes, morning to you all. Morning to you all, colleagues. Yes, as I've been introduced, my name is Martin Senjona. I'm the current head of department for quality of care. We have a long nomenclature: standards, compliance, accreditation, and patient protection. We are very happy to see you, all of you, in your different capacities. Thank you very much for responding to our invitation. We expect many more others to come and join us. But we as a department and the Ministry of Health in general want to thank you so much, the good work you are doing there. We really appreciate. I know it's an opportunity now to share the experience, to share what you have been doing in different areas. But I think at the end of the day, the patient, the client, are the ones that really learn, appreciate, they get the end results, the services. So we want to thank you so much for the continued service, despite the challenges we have in the system. But I think, all in all, everybody is doing the best so that the patient gets quality services. So this morning, as we start on the 3-day engagement, we are going to start with we have 2 important documents that have been developed. Of course, involve you participating. The first one is a report, Harmonized Health Facility Assessment Report. We have the team leader, Professor Christopher Orach. You know him very well. He's our teacher, and has worked with us at the ministry to see that we have this report. He's going to tell you the story, what it's all about, and then we can have a brief discussion. Then second, we are going to have another document. These 2 documents are going to be launched by the Honorable Minister when she comes. So I want you to be familiar what they are all about. And then at the end of the day, we want them to be of use and of value to the work we are undertaking. So the second document is a guide to implementation of the maternal, reproductive, maternal, newborn, child, and adolescent health services. Quality of care. It's a guide to the implementation of quality of care. As you know, this is also a very important area. The mother and the child is a very sensitive indicator for quality of care, and many things are happening. Many of you are participating. So we have put together the different entities we have, the different standards, the different approaches into one guide, so that whatever we do is institutionalized and can last as long as it can take. So Dr. Munanura Tuliasima has just come back fresh from Jerusalem University with a master's in public health. I want to appreciate and congratulate him. He'll be the one making the presentation, but we are starting with the Harmonized report, Harmonized Facility Assessment Report. And allow me at this juncture to invite Professor Christopher Orach to make his presentations. We are going to avail the soft copies. It's a big document. I think it's going to show you the type of report we are talking about. We have a few copies for the regions, at least the minimum, but we shall make sure they reach you. You get the copies in your working in our different stations where we are operating from. So can you give an applause to the professor kindly? Professor, you're welcome.
Ladies and gentlemen, in all your respective capacities, I want to greet you, and I want to say that we are pleased to share with you the output of our work related to the first Harmonized Health Facility Assessment. One of the first few in Africa, and definitely the first in Uganda that we conducted. Supported, commissioned of course by the Ministry of Health, and supported robustly by WHO, headquarters, the region and the country office, and implemented by Makerere University School of Public Health, the team that I led. We conducted this work. Let's go to the first, the next slide. I can do it here, I think. We conducted this work during the year end 2022 to about the middle May of 2023. The Harmonized Health Facility Assessment is like, and it is sprouted from the Service Availability and Readiness Assessment, which has been conducted in Uganda several times. The Harmonized Health Facility Assessment has 4 components: the service availability, the service readiness, quality of care and safety, and management and finance. Our team only picked, because of the resource envelope we had, we picked the first 2, but we left the other 2 because that needs the tool, the instruments to have it implemented wasn't ready yet. And that's the next piece of work that lies ahead. Overall, the objective of the Harmonized Health Facility Assessment is that we want to generate evidence based on, of course, quality data to guide efforts by the Ministry of Health and practitioners to deliver quality services and practice. That's the overall objective. How did we do this? Ladies and gentlemen, this was a countrywide study conducted in all the 15 regions of our country. We went to 642 health facilities across the country, all the national referral hospitals, 17, and in fact all the regional referral hospitals, 62 general hospitals, and we took 10% of all the health centers, from health centers 4, 3, 176, and 2, 233. We used the WHO adapted standard health facility assessment tool. We collected data using electronic devices, and analysis was done based on WHO automated online platform. I will go straight to some few findings. This document, which will be launched today, is about 500 pages. A few regions and districts will get a copy of this, a hard copy. We have the soft copy with Dr. Martin. St. Jonah. So I'll give you just a highlight, brief highlight of what we found. And this is only the tip of the iceberg. We look at 7 areas: reproductive, maternal, adolescent, neonatal healthcare. But in terms of, for example, natal or delivery services at health centers 3s and above, we found that in these facilities, the availability of these services was at 90% of natal services. This is what was happening. On a happy note, we found that delivery offered on a 24 daily basis by skilled providers in these facilities was at 89%. However, basic emergency obstetrical care was also relatively high at 84% in terms of the delivery. But if you look at all the 7 components of obstetrics care, including neonatal care, this was much lower at 10% for the lowest bar down. If now we look at immunization services in terms of facilities offering, okay, we found that 79% of the facilities offered immunization services. However, for children under 1 year, 78%, slightly lower. This, we noted, is below the Gavi target of 90%. We found that in the regions, facilities in Bunyoro was offering, the services were offered at a relatively low rate, 58%. Kampala too was low, 50%, Teso 56%. These were regions that had facilities offering relatively low immunization services. We found that the majority of government facilities, 90%, and private not-for-profit facilities offer these services at, 3/4, 75%. Okay. However, private health practitioners were not offering these services, and it was offered only at 40% in their facilities. Now, a little look at communicable diseases. Let's start with tuberculosis.
driven activities to really people-centered healthcare. And it means practicing healthcare in partnership with the patients and with individualized attention to each person's unique needs and perspectives. It's a really exciting area of work, and we think another field where Uganda is really going to lead the way in the health sector and globally. This is one area I did want to add where we do have particular concerns around the Anti-Homosexuality Act and the barriers that can pose to realizing this goal. If there's an environment of fear or uncertainty or a concern about reporting, then it can result in a change of how or if vulnerable people seek care. So while we think this is a tremendous opportunity moving forward, this is part of the reason why this legislation is so concerning to us. And so I wanted to add that point. Uganda's made really significant strides over the past decade in addressing discrimination in the health sector, and we want to see this move forward, and we want to be part of that journey as well. Using a patient-centered approach, we can build a strong and resilient healthcare system that serves all members of the community equitably. The second priority that I really wanted to highlight is the People's Voice Survey. So this is an innovation that we're excited about introducing with the Ministry of Health. It's a new survey that's rapid, low cost, and population representative. If you are not familiar with this survey, there was a Lancet series, a Lancet Journal series that was published just less than 2 months ago. And the series outlines how this survey has been implemented in 14 countries around the world, including some of Uganda's neighbors in the United States. And for those of us who've been part of work to do exit surveys or try other methods to understand people's experience of quality of care, this is really an exciting innovation. The survey, which is phone-based, aims to promote health system accountability to the population. It can track the impact of reforms and policies over time and inform actions towards a more effective and person-centered health system. The process is that you call individuals around the country and gather information on their experience related to the quality of care they received over the past 12 months. As we use this approach to expand the pool of individuals who can actively advocate for the health system, we can accelerate progress towards our health goals, including controlling malaria, reducing teenage pregnancy, and putting an end to the HIV epidemic. The third area of innovation that we are particularly focused on is looking at taking our approach to quality improvement beyond just the facility level and specific outcomes, but applying the same principles to redesign and enhancing systems at the national, regional, or district level. This evolution in strategy from focusing on health outcomes to full systems redesign is a key topic in the global discourse on quality improvement. And it marks a significant shift in mindset from enhancing what exists, like improving a candle, to innovating entirely new solutions. So in this case, creating a light bulb. I had a copy of my speech out last evening, and my 10-year-old got a hold of it, and she was looking at it, and she said, "Mom, I hope before you go tomorrow, I see something about a candle and a light bulb here. I hope you make sure what you're saying makes sense before you say it in front of a big group of people." Oh, and it really stuck with me. But I love this analogy and thinking about the work that we're doing right now on improving newborn results, looking at complementary feeding, looking at ANC. All of these specific health outcomes are amazing and have really achieved results for Ugandans, and taking those same principles to tackle some of those really sticky systems issues like commodity accountability, the management of district health systems, health worker performance is an amazing opportunity to move forward. So we as the US government are really committed to being with you and part of these innovations and part of the change that's sought by the stakeholders who are here today. Your daily efforts, especially in this environment, are impressive, and we look forward to seeing all of the presentations and posters over the coming days. Through collaboration, we're certain that we can achieve sustainable improvements in the health system. On behalf of the US government, I express our profound gratitude for your commitment and wish you all a fruitful, cooperative discussions throughout the conference. Thank you.
Thank you very much, Jessica. Another round of applause. This is the first Quality Improvement Conference you are attending, and we welcome you, and we appreciate the highlights of the priority areas for focus that you have given us. You're most welcome. Okay, so now we receive remarks from WHO, country representative, represented by Dr. Elizabeth Mugambo Adhiambo. Please welcome her to make remarks. You're welcome, Dr. Elizabeth.
The Honorable Minister, representative of the Director General, directors and commissioners of the Ministry of Health, district health officials and healthcare workers in the House, the health development and implementing partners, all guests and delegates, ladies and gentlemen, good morning. Good morning again. Yes, so to introduce myself again, I am Elizabeth Mugambo, Emergency Preparedness and Response Team Lead in WHO Country Office. But today I'm here on behalf of Dr. Jonas Tegen, who is away in a mission. He sends his greetings. Just also to highlight that I've been a quality improvement champion in my former life, and I think this has also lived with me, and it has become a way of life. We all know that with quality improvement, it applies in everything that we do. So I am really happy and honored to be with you here today. So I am pleased to be part of this 10th National Quality Improvement Conference. The theme, Innovations to Strengthen Health Systems for Delivery of Quality Healthcare in Resource-Limited Settings, is timely, as we are 6 years to the end of the 2030 Agenda. Although progress has been disrupted by various public health emergencies in the recent years, innovations for strengthening the healthcare systems will actually play a pivotal role in accelerating our progress towards universal health coverage. Indeed, Uganda is a hub of innovations. Uganda is a country where the country that leads the way in most of these initiatives that comes along. And this, together with a 15 years journey in quality improvement, plus many other interventions in the country, have yielded results. And as a result, Uganda's universal health coverage index has progressively increased from 22 during the year 2000 to 49 in the year 2021. This is no mean achievement, and we need to applaud the country for that. This is a big improvement because even a 1-point improvement in universal healthcare coverage index is really, it takes a lot of effort to get there. So even with the increased access to services, health improvements can still remain elusive unless the services are of sufficient quality and are effective. This conference therefore provides an excellent and timely platform for reflection, for learning, and also for refinement of the innovations for strengthening health systems in order to deliver quality healthcare and accelerating progress towards achieving UHC. And indeed, I believe there'll be a lot of learning that will take place. Yesterday I was going through the agenda and going through the various presentations that will take place both for the orals, for the poster presentations across the different building blocks for the health systems. It was quite amazing to see all that. Really, I counted there are over 200. And I was like, wow. And when I was looking at the titles for each of them, it was so impressive. And it is my hope and desire that during this conference, the learning that will take place will go a long way and be weaved back into, or scaled up even into higher levels. And there will be cross-learning also taking place across the different levels of the health systems. Ladies and gentlemen, innovative actions to strengthen the health system should aim to achieve health system resilience. And resilience is a situation in which all health-related actors and functions collectively mitigate, prepare for, promote, and recover from disruptive events while continuing to provide essential health services and functions. These actions should be guided by some core principles. But before I go to the core principles, resilience is key, building resilient systems. Especially in this day and era, we have all seen the impact that we've experienced from the COVID pandemic. Again, for Uganda, EVD outbreak came. It was controlled really in a very short time. The country did a lot. But still all these impact progress and they impact delivery of these essential health services. So therefore, we really need to work together to build the resilient health systems. And these are the core principles that will guide this: government, ownership, and leadership. And for sure, we have seen this for Uganda. Honorable Minister, we appreciate the leadership. We have seen your commitment. We have seen the determination. We have seen your drive for results. And this translates to the entire system. It also requires a whole of government and whole of society approaches, because when we look at a number of issues that come to the health sector, for some of them we are on the receiving end, but it needs other sectors to come together when it comes to that prevention to ensure that we are not always on the receiving end. So we have the social determinants of health, and therefore the whole of government approach becomes really very critical. Leaving no one behind. Again, this is an important approach, that no one is left behind. Again, another principle is on sustaining essential health service delivery while managing health emergencies. Again, this, we cannot overemphasize on this, but we all know and we all have seen this. Engaging and empowering communities. Communities are at the forefront. Let communities continue also having their voice, speaking so that they are heard. And through empowering communities, then we are able to come up with approaches that are able to address really the specific needs of the individuals and also of the communities. Learning from the previous emergencies and to improve health policies and interventions. Every emergency is always a learning opportunity. There is always something we learn. There is always something we learn that we need to do differently. And again, with emergencies also, they've also provided an opportunity to further enhance and build the existing health systems, because everything always starts from where we are, from what we have. And I really want to applaud Uganda also on this, even when it comes to the health emergencies. I see the coordination is at another level. I see the emphasis on using what already exists and improving on that. Because sometimes you could have instances where, if this is not done well, you find many innovations but outside the mainstream health system. So in the end, once funding is gone, nothing is left. Everything is closed. But I have seen in Uganda there has always been an emphasis on using what exists. And therefore that provides an opportunity also to further enhance the health systems. So towards improving the quality of healthcare in Uganda, the World Health Organization continues to provide technical support in the development and implementation of a national quality strategy, the development of quality of care measurement frameworks, and promoting of patient and healthcare worker safety initiatives. We have also worked closely with the government, with the Ministry of Health, with the partners, in strengthening of infection prevention and control practices and the country efforts towards community engagement to achieve integrated people-centered service delivery systems, though a lot still needs to be done. And again, we are looking forward to keep on working with the government, the Ministry of Health, and also all stakeholders on these areas. So ladies and gentlemen, as I conclude, I thank the government of Uganda, the donors, the implementing partners, frontline health workers, and communities for the great collaboration that has enabled the country to achieve the milestones towards the delivery of quality care at all levels of the health systems. I call upon all stakeholders to use all the lessons from this conference to build strategic partnerships and to scale up the innovations that will strengthen resilient health systems with quality healthcare provision. Indeed, building strategic partnerships is important. We all need each other, we all have different strengths, and this diversity, while leveraging on the strengths for different partners and also different members within government, different teams, different levels of the health systems, this is what will get us there. We all need each other, so let us all keep working together towards this. I wish you all successful deliberations. Thank you.
Thank you very much, Dr. Elizabeth, for those wonderful remarks. Another applause. Let's appreciate remarks from WHO. Okay, so now it's my pleasure and honor to invite our chief guest, the Honorable Minister of Health, Dr. Jane Ruth Acheng Ochero, and a Member of Parliament for Lira City, to come and greet us and officially open this conference. You're welcome, Honorable Minister.
Thank you very much, Dr. Kware. Since you said I first greet you, allow me to greet all of you. Good morning to you all. And thank you very much for coming in such big numbers. Our development partners, the Director, Health Services, Governance and Regulations, our health implementing partners, officials from ministries, departments and agencies, representatives of civil society organizations, the health professional councils, directors from both national and regional referral hospitals, district health officers, the media, invited guests, and all conference participants, including those online. It is a pleasure to welcome you to the 10th National Health Sector Quality Improvement Conference. You know, you sanitized this place, and the microphone is just sliding away. I need it cleaned a little bit so that it can remain in one place. So allow me to welcome you all to the 10th National Health Sector Quality Improvement Conference, and also to appreciate you for taking off time to come and spend 3 days discussing quality improvement. I also take this opportunity to thank you for the work that you're doing in improving quality of health services in this country. Listening to the speakers before, we are all aware about the progress that we have made, and yet a lot still has to be done in many areas if we are to offer quality services to our people. I want us today to reflect a little bit on the health systems building blocks of WHO. When you look at the various parts in the 6 areas, there is a lot that needs to be done in the areas of governance and leadership, health workforce, information systems, service delivery, medical products, and financing. And I am glad that each of the speakers that came here mentioned these areas. We have 6 years left to 2030. And everybody thinks 2030 will be a miracle year. Many of you will recall the Millennium Development Goals. I think somebody's microphone has just fallen down. Many of our African countries have an unfinished business as regards the Millennium Development Goals. And this unfinished business keeps on pulling us behind, even when we try to move forward with the Sustainable Development Goals and also our quest for universal health coverage. There are challenges that we continue to meet, especially in the areas of financing. And the good news is that financing is not improving. Now, many of you are now very alert asking me, is that good news? Yes, it is good news. It is good news because then it takes you to the innovations that you're talking about. We need more innovations so that we can continue to strengthen our health systems. And we don't need very expensive innovations. I will tell you something that happened recently, not very long ago. And there are some people in this room here who are aware. The 11 high-burden countries for malaria were invited to Cameroon for a meeting. and I was part of it. At least I know WHO is aware and USAID is aware. During that conference, reality set in because it was very clear. Partner after partner came to speak, and they said the world has moved on. They have moved on to climate change, to global health security, to wars in the various areas, and for you, you are still on malaria. You are still on malaria and TB. We've moved on. So you need to look for your own domestic resources and end your malaria. End your what? You say my malaria. Yes. We need to look for our own domestic resources and end our challenges. And we can only do that with innovations and quality. I was very happy during that conference, and by the way, there was a declaration. In that declaration, we are all declaring that we are going to get our own resources. So I declared on your behalf. Yes, I had to declare, whether you are happy or not happy, all the 10 countries, 11 declared. And I have the declaration with me. And when I do it, I have done it on your behalf. And I was saying that I was happy. Happy because we need quality even in our financing. We need to be people who are realistic, that every dollar, every penny should translate into something tangible to touch the lives of the people. There is a lot of wastage in this country, genuine wastage. At every step, every process, we have wastages. We need to start tightening the nuts along the lines of wastages and put in more innovation. Not only in financing, we need innovations in ensuring that our medical commodities, the products, the technologies we are using actually benefit the end user. Are we able to track our medicines up to the beneficiary? And when you're asked for accountability, can you, by a click of a button, produce accountability? We need quality in service delivery. Do we keep time? And do we do what we are supposed to do adequately? Or we all come and we practice being around. And there is a lot of being around even in conferences, because we walk in with our phones, mobile phones, laptops, and somebody is talking and we are busy on WhatsApp, SMS, you're laughing with the, people, and things pass you by. And when things pass you by, you have missed the point here, you continue to miss that point. And we pick on this, carry it with us into our areas of service delivery, and there is no quality. We are losing maternal lives because we are not concentrating, because we are not thinking, because we are not giving in enough time. I was challenging people during the conference where we were discussing blood a few days ago, the African Society for Blood Congress. And I said, for a long time in this country, we have relied on blood from our children, because when the schools are closed for holidays, there is no blood. And then when the schools are open, we are all running to look for the children because we want to bleed them. And yet, the age for donating blood ranges from 17 to 65. meaning that all of you in this room are eligible donors. But why don't you want to donate? Then all of you will be saying, we are not sure of ourselves. And yet you are the people that are discussing quality. If you're not sure of yourself, why don't you go and find out so that you become very sure and you know whether you can donate or not donate. Suppose one day the children say, we are not giving blood, don't come to our schools. Are we going to die? Are we going to die? Yes, we are going to die because many of you here don't want to donate blood. So I am challenging us at every time that we are doing something and you're thinking about quality, also think about the lives of the people and think about yourself. What if it were you? I was told of a story of a pregnant girl, 17 years old, recently, severely anemic, with difficulty in breathing. Perhaps she was in failure. In a health center she was put on blood, she was not improving, and she was transferred to a regional referral hospital. Upon reaching there, the regional referral hospital received her, attended to her, and after a few hours they wanted to discharge her because there was no blood in the regional referral. Now, discharge her from a regional referral to go where? To go where? And yet she has come where there are specialists, where there is equipment, where there is better health services. Now, she has come from a lower health facility to a better facility. The better facility wants to discharge her. So which one is the better one? Isn't it the one that received her and gave her some blood? The health center You can imagine the irony of things and the challenges of the system in which we work. So even when we are thinking about quality and innovations, let's ensure that the products reach the people. Of course, the other areas of governance and leadership are extremely important. And you must lead by example. You must be a committed leader, not a politician. There is a difference between politicians and leaders. But there are times also when you can interchange. One time you are a politician, another time you are a leader. But it is always good to be a leader so that you inspire people to do the right things. But don't come and tell a lot of lies and then there is nothing done at the end of it all. There are many of our leaders in our health system at every level who are very good politicians. Even when we go for support supervision, they will say all the nice things, but when you go to look for the nice things, you will not find even one. In other words, they are absolutely absent and only present when people go to see them. So this conference is yet another opportunity for us to share experiences, challenges, and opportunities, and tested solutions in the implementation of quality improvement healthcare in our country. There has been a lot of effort in trying to ensure that we instill quality at every step of our work. I recall there were many hospitals where 5S was introduced and supported by JICA. One of them is a hospital where the director governance comes from, which I visited recently. And I wanted to see the traces of 5S. The traces. I'm just talking about the traces. I looked around, I tried to bend. And yet, these were serious investments in terms of dollars. So one of the painful things we go through is that when we are getting support from partners, we are all into it. When the partners withdraw, we also withdraw. And the painful thing is that we are withdrawing from our own systems. The partners come in to support. So if you withdraw with them and you destroy the system, then was it really worth the support? I really want to urge us all to be more committed. I also want to encourage the planners at the Ministry of Health to pick and take note of the various issues or innovations that need scaling up at all levels of the health system. I love the theme, innovations, and as I mentioned earlier, it emphasizes the need for strong health systems for quality health care. It calls for all of us, players in the health sector, to use these innovations, and remember I said they don't have to be expensive, amidst our challenges to improve the quality of care. You can even use innovations to improve the lead time for procurement, lead time for requisition of funds, lead time for many things. In some of our institutions, including the Ministry of Health, some procurements can take 3 years. Can we put in some innovations? Shorten the time period, get the things out early. Requisition of funds just to go and do something. Perhaps there is an outbreak somewhere. It takes like forever. And then the minister has to run to WHO or USAID. Can you please chip in quickly as we are still going through the bureaucracies of government? We can shorten that. And that is putting quality in our actions. It also dispels the belief that quality of healthcare services can only be improved with a lot of resources. And that is why I started by telling you that now reality has set in and we have to demonstrate that improvement can be achieved within the limited resources. I would like to urge all participants in this conference to use the opportunity to continue highlighting and sharing the unique ways through which you are using quality improvement initiatives to improve service delivery in your areas of jurisdiction, and also to ensure that quality improvement is institutionalized at the different levels of the sector and come up with solutions that can be shared across the board. The ministry will continue to make investments in the national health system. Many of you are seeing the infrastructure that government is investing in, the health center 2s, the health center 3s, which is meant to ensure that we reduce maternal mortality and child mortality as much as possible. And I am glad that we set targets, and now we are going to launch the guidelines to help us implement the various documents that we have at hand. In a special way, I would like to appreciate His Excellency Yoweri Kaguta Museveni, the President of Uganda, who saw the need and the importance to enhance our salaries. Unfortunately, yes, everybody is, some people want to clap, others are not, perhaps others did not benefit. Unfortunately, it is very clear that the salary enhancement has not translated to better quality. It is very clear. from the surveys that are being carried out by Ministry of Finance and others, it is not translating into better services, better quality, and we are yet to see if it will translate into better health indices. So I would like to appeal to all of you to do more, to sustain what we have already achieved, and also improve as we move forwards into the years. The people we serve are yearning for better results. We look forward to a time when we can work very closely with all of you through one plan, one budget, one monitoring and evaluation. And we are going to be very serious about this. We don't want any more fragmentation, silos, vertical programs. We need to integrate everything under one leadership so that we can all boast of our achievements together. And when we have not done well, we also look down on our failures together. As I conclude, allow me to appreciate our development and implementing partners for supporting the initiation and growth of quality improvement initiatives in the health sector and bringing us now to the 10th conference. We are very grateful to you all. I would like to recognize the SCAP department at the Ministry of Health under the leadership and guidance of the PS, the DG, and the Director Governance for steering quality initiatives in the sector. I would also like to appreciate in a special way the frontline health workers at the facilities who are the foot soldiers of change towards improved health service delivery that we have achieved so far and where we are going. And also to continue to remind you, especially the frontline health workers, that even as you give services, remember to protect yourself. That is part of quality. Remember to protect yourself. Uganda is a country that is very vulnerable to outbreaks. Even when the system is quiet now. Is it quiet? Is it quiet? It is not quiet. Don't we have foot and mouth disease? So it seems some of you, those who said yes are eating meat. I am sure that all of you saw the letter saying don't eat meat in Kampala. So we shall check today if they have cooked meat here. Allow me to congratulate all those whose abstracts were accepted to be presented and discussed in this conference. Finally, allow me also to appreciate those who are online, who took off time to join us in this conference. And before I take my seat, I would like to thank the following in a special way. The Global Fund, USAID, Uganda Health Activity, the Makerere University School of Public Health Monitoring and Evaluation Technical Support, that is METS program, USAID Family Planning Activity, Japanese International Cooperation Agency, JICA, USAID, maximizing options to advance informed choice for HIV prevention. USAID social behavior change activity, and the Uganda COVID-19 response and emergency preparedness project. All these partners made it possible for us to be here today. Allow me also to recognize and appreciate our keynote speakers who have taken off time to prepare the keynote addresses to share with us extensive knowledge, experience, and also encourage us in our quest for quality improvement. I would like to recognize Professor Handa Ujiro from JICA, Professor Henry Tumwine from Kavala University School of Medicine, and this one, by the way, is my teacher, and Professor Peter Waiswa from Makerere School of Public Health. I thank you all for listening to me. It is now my honor and pleasure to declare this 10th National Health Sector Quality Improvement Conference 2023 officially open for God and my country.
Let's put our hands together again to appreciate the Honorable Minister for officially opening the conference. Honorable Minister, we have listened, and the country has listened to you attentively. Thank you for the straight talk. We need to tighten our belts because the road is getting rough and rougher each other day. Once again, thank you so much for those words of caution and guidance as the political lead of the sector. Innovations throughout the system, health system, will lead us to quality and better results. Now, Honorable Minister, we are moving on to launch the 2 documents, and then thereafter we receive our first keynote address. It will be less than 20 minutes, and it's around the same issue of health system strengthening. The keynote address will be delivered by Professor Peter Waiswa from Makerere School of Public Health. Waiswa, I'm corrected, Peter Waiswa. And the address will be around understanding health system strengthening in a resource-limited setup. And that's what Honorable Minister has just been talking about. So may I now invite the officials that will join the Honorable Minister to come and launch these 2 documents. May we have the copies ready and the markers ready for this exercise. We need the copies also ready. They're ready. So let's have WHO, USAID, Dr. Elizabeth, Dr. Jessica, JICA, chiefs of parties, or officials representing our partners, the chiefs of parties, UHA, UHSS. If you are present, please come forward. Directors of regional referral hospitals, if you are here, please come forward. DHOs, please come forward. We have Makerere University School of Public Health. Please come forward so that you be with the Honorable Minister as we launch these two very, very important documents. One, we shall start with the survey, the report. And Professor, you can say something about the report. Just a summary, because she missed the presentation in the morning.
Yes.
Yes, my teacher too.
Honorable Minister, our report found that overall general health service index in the country has increased to 59% from about 48% way back in 2018 based on the SARA finding. This is one. Two, we found that overall services availability in the country at the national level, at the regional level, in the higher level facilities, the national referral hospitals, the regional referral hospitals, the general hospitals, is as expected higher, but at the lower level facilities, the availability still remains low, as would be expected, especially in the areas of communicable diseases, immunization, and so on, where we found, in these areas, we found generally availability of services were good. Of importance, Honorable Minister, we found that readiness to provide services, especially for non-communicable diseases, cancers, remain low. This is an area that needs focus. We also found that readiness to provide emergency services, especially transportation systems, needs to be strengthened. This is what I like to report to you very briefly. Thank you.
So, Honorable Minister, we now invite you to launch the Harmonized Health Facility Assessment Report. Thank you very much. Applause. The hard copies are available, voluminous and rich. Can we have the other officials to sign this as we prepare to launch the next document, the guidelines? In the meantime, Dr. TMK, please summarize what this next document is all about.
Honorable Minister, I present the Quality of Care Implementation Guide for Reproductive, Maternal, Newborn, Child, Adolescent, and Nutrition Services that was developed by Ministry of Health under SCAP leadership and reproductive health and implementing partners support. This guideline outlines the organizational structures at the Ministry of Health, at the center, and all levels of care. It outlines the leadership and governance and accountability for RMNCAH services, also at regional level, district and community level. It also outlines the quality improvement activities that will be implemented to improve RMNCAH services, and later describes the data management systems, including the monitoring and evaluation frameworks and indicators for RMNCAH services. And finally, it describes the RMNCAH research agenda that will be used to implement RMNCAH services. So this is the guideline that we present to you for launch. Thank you so much.
Thank you very much, Dr. TMK. Honorable Minister, we now invite you to officially launch the Quality of Care Implementation Guide for RMNCAH and nutrition services in the country. You have the copies. Thank you very much. Let's now sign, continue signing. WHO, you are the mother of guidelines. Once we see your signature there, then we know that this is authentic. The cameras should get ready, because after this we take a picture and then we take our seats again to listen in to the keynote address. It will be brief. Then after the keynote, we go for coffee. Sign. USAID, sign.
So as the signing continues, I've been requested by Director to inform you on how the photo shoots will be. The first shot will be the Honorable Minister, the Senior Management of the Ministry of Health, that's the commissioners, assistant commissioners, of course, and the Director, and development partners. That will be shot number 1. Shot number 2 will be the Honorable Minister, of course, the commissioners and assistant commissioners. Those are constant and development partners. Then the addition will be the IPs and those from academic institutions. So the first one has the constant, which I've said, the Honorable Minister, commissioners, assistant commissioners from MOH, and development partners. Okay, the big one, so others will stand up, and then we shall start by separating. Those of you who are vertically challenged, you just take up the podium.
We are done.
So thank you. So the ones in front can stay, of course, the Minister of Health, and then the development partners. So that's the first one. Not really. You can just put them down. Because the books are too heavy. Okay. So let's take, if the books are heavy, okay. So Alex Benson up. Very good. Of course. Director Joseph, you can stay down for obvious reasons. Vertically enhanced. Okay, the second set will include the IPs and those from academic institutions. Professor Raj, no, those you are constant, MOH you are constant. Hey. Okay, now we have the, yes, okay, academic institutions, okay. From academia, please, can you join in very fast? Let's do it fast. You are key. You are very instrumental because you skill the health workforce. The cameraman, you let me know if it's not balanced. Are you done? Okay. Now we go to the other one. So the constant ones you stay. So we need now the DHOs and director of regional referral hospitals. Just to be. Of course, the last one will be the same constant with the presenters. So the DHOs and our directors of regional referral hospitals who are around, please, we like you so much because you are our frontline team members. Okay. Dr. Kware, if you go upward, our photos will be out of focus. They will be over-skewed. You just, Nia Musajja wa Kabaka, so at least that's fair. DHA, Dr. Kamye, you are most welcome. Hey. So the camera crew get that one very well. Thank you so much, the DHOs. So the constant is the last one. The DHOs and hospital directors you can get off. So now with the presenters. The presenters who are around, yeah, because you are going to enrich our conference over the 3 days. So Professor Peter Waiswa, for you, you will be online, you will miss out. So we shall do some Photoshop editing just to put you on, and maybe the other keynote. Please go behind, don't widen it. Just go behind. Yeah. Honorable Minister, we have a number of presenters, both oral and poster presentations. So they will find themselves, that's why the number is big. No, you just, if you want to appear in the photo, just go behind. Because it won't. So even if you stand in front of Director Joseph Okware, you want to be affected. So for you, I've decided to. No, here you are not seen from here. Uh, yeah, the gentleman, you can do the needful, you can just squat in front. So the online presenters, you just turn on your videos thereafter, and we shall see how to merge them. Benson will appear in all the 5. Okay, the last shot. Okay, thank you so much. And over to you, Director Kware, to take us to the next.
IT. Okay, so welcome back from that session. The conference is now officially launched and opened. The 3-day QI conference is now opened. And we are ready to receive our first keynote address. I just want to make sure that the IT people here are compliant. Dr. Waiswa, or Professor Peter Waiswa, are you able to hear us?
Yes, I'm able to hear you. Can you hear me?
Very good. We want to see your face. Are you?
Recording stopped.
So, Dr.
Recording in progress.
That echo. Dr. Waiswa is an associate professor of Health Policy, Planning and Management of the School of Public Health at Makerere University College of Health Sciences. His focus areas are mainly health systems, implementation research, and policy influence in reproductive health, maternal, newborn, and child health. Dr. Waiswa is a member of the WHO Quality of Care Uganda and global networks, and has led many QI innovations in the health sector in Uganda. IT professor is not able to hear us. Professor, can you now hear us? Can you hear me? Professor? The echo. Why are we getting this echo? Hello? Professor, we can hear you loud and clear.
Okay. Thank you so much for the invitation. Honorable Minister, the USAID Health Country Representative, Jessica, and that you're up to Uganda before. apologize that I'm not with you. I'm actually in the restaurant for a meeting, and I just got this invitation to present last Thursday, which made it difficult for me to be with you. So I apologize for that, but I would have wanted to be with you there. My presentation is understanding system strengthening in resource-limited settings like Uganda. I must say, the minister, the USIPD representative, and the people have already talked about most of the issues I'm going to talk about. I just wanted to start with what I call a key message for my presentation, and I'll come back to it at the end. That health system strengthening requires one, capacity to manage complexity. So health systems are complex, and they need to learn how to manage. And management for me is a critical word to manage complexity, to deliver integrated and good enough minister, as I emphasize this, packages of evidence-based interventions with a target goal in mind. And the goal for the health system is actually to improve health outcomes. Now, we are talking about health system strengthening. What is a system? A system is defined as any group of interacting, integrated, or interdependent parts that form a complex, and the unified whole that has a specific purpose. As you can see, health systems are not just people, not just clinics, not just hospitals, not just the Ministry of Health. They are different components that must be working together in an organized way for a specific goal or purpose, which goal is to improve health outcomes. Now, this thinking about health system is actually a bit recent, because the world historically has been a world of medicines, of vaccines, and hospitals. But in around 2000, in a report by WHO, which is made by the Alliance for Health Systems, the World Health Report 2000, which was Health Systems Improving Performance. This is the first time that WHO systematically started bringing the issue of health system at the fore. And over time, almost every year, WHO publishes different key documents from the Alliance for Health Systems that talk about what are health systems. The most recent, where system thinking was defined, was 2009. And after that, we've gone through various improvements in understanding what health systems are. Now, in the report of WHO in 2007, WHO defined what are health systems. And I think it's important that all participants have a good grasp of what are health systems, because once you understand them, then you can think of how to manage them. They were defined as all organizations, people like health workers, like sweepers, like community workers, and actions like immunization, health promotion, treatment, whose primary intent is to promote, restore, or maintain health. And the WHO went on to add that this must be done in a way that improves health outcomes in an equitable, responsive, and financially fair, and make the best use of resources. So the minister has talked a lot about efficiency. Efficiency is at the core of the systems. We cannot be wasteful. And she said that she's happy that we don't have much money. And I also agree. I always say the measure of a good manager is how much you have done with the resources you have, or with what you can do as a manager before you ask for more. So that is, supportive of what the minister said. We all know that health systems are actually different levels. Primary care, which includes communities and community facilities. Secondary care, which includes most of the general hospitals. And tertiary care, which is mainly regional and also national hospitals. At all these levels, we need health systems strengthening. consists of what WHO gives as 6 building blocks. I must say right now, there's an effort to expand on the building blocks because they find that other systems are important in influencing outcomes of their systems. But sorry, all of a sudden the internet has been good as become problematic. So I was here. I hope you can see the presentation. But we take the building blocks as the main as of now. Governance, human resources, financing, service delivery, health information systems, and medical products are the building blocks. Now, typically we think that when you have inputs, money, etc., let's work first, you get outputs, and you get outcomes, and you get impact. The minister has already alluded that we've increased the pay for health workers, but we don't have outcomes. Because mainly, we have done one component, which is basically improving service, but systems are complex. Systems are not linear. Systems are not linear. They are not from input, output, outcome, impact. Systems are complex. We need systems thinking if we are to have the impact we need. And the WHO has defined systems thinking. That systems thinking is an approach to problem solving that views problems as part of a dynamic system. So it is a problem. It is not enough to increase pay. Systems thinking involves more than a reaction to the present outcome or events. Like payment is just one of the problems, but we need to go beyond it. It demands a deeper understanding of the linkages, the relationships, the interactions, and the behaviors among the elements that characterize the entire system. So we need to think beyond WHO said that it is not a linear system. Health systems are interconnected. Look at what is in red. Health systems governance interconnects with medicines, with human resources, with the information system, with others, in order to serve the people. What happens in the spaces between the subsystems, like governance, like human resources, like financing, is important as what goes on with them, and is usually neglected. This is the core of system understanding, systems thinking, and also the systems thinking. The fact that systems are complex, are interconnected. Because systems are complex, they are always self-organizing. You increase the pay of health workers, they find a way to do it. Work. They are constantly changing. And then others whose salary was not increased begin to complain because they are interconnected. And getting change becomes a problem because there is usual feedback. Because systems are complex and are interconnected. So let me give one example, and I think I was chosen here an example of quality improvement in my presentation until the minister gave the one of payment of health workers. But let me take what the conference is about, which is quality improvement. You decide that you are going to do quality improvement. That is a governance decision, which is good. But it's not enough to say you do quality improvement and it will improve service delivery. You go straight to improving service delivery because you think maternal death is not reducing, let's go and do quality improvement without thinking about other systems. What are the information systems? Is it showing that the health workers are present? Is it showing that the commodities are there? Is it showing that the human human resources are there. Is this showing that the actual quality improvement that we are focusing on is actually available? And are you looking at the people? Are the people even accessing this care? So it is not enough to have a quality improvement intervention. A lot of them are in the room. It's better, Prime Minister, what we see that most quality improvement initiatives do not necessarily have quality in them or enough quality. And two, they may not lead to, a lot of the reviews show that many quality improvement initiatives don't lead to improved outcomes because of all these complexities that happens in the system, that things which need to be in place in order for it to work. And that requires a system strengthening. So therefore, what is a system strengthening? First of all, from a policy perspective, we have the minister, we have many policy makers here. So from a policy perspective, intentionality is the process of identifying and implementing the changes in policy and practice in the country's health system so that the country can respond better to its health and health system challenges. It starts with a policy intention and being clear on what is the policy. And I think it is very good that the minister was spelling out all those things she wants to see in the system, like a one system in terms of projects, in terms of financing. I think that is a good policy direction. But of course, policies need to be implemented. Now, at a more local level, at the implementation level, the system strengthening is defined as improving the 6 health systems building blocks and managing their interactions in ways that achieve more equitable and sustained improvements across the services and the outcomes. What this means that these building blocks and their consequences and their interactions need to be managed. The word management, I'm underlining it because I find it a critical gap within the system. Even today, we are struggling with, even me, I'm struggling with my presentation not being on time, but also the conference being on time, because the conference management may not be an expertise of the doctors. WHO goes on to say that health system strengthening is a comprehensive, so it's not simple, it is a comprehensive and sustained. Sustained becomes quite important. Enhancement of the capabilities, the performance, and the resilience of the systems. Managing those interactions intentionally to make sure that they are well managed efficiently to produce the outcomes that we want. I will give you some examples of what are some best facts about a system that is working or that can be strengthened. And one, I usually say that to have impact or to have a system strengthening, you require good coverage. How many people are we reaching? But also quality. And when we talk about quality, the issue, it is not simple, small interventions. It is package of interventions that make a difference. There's an pay of doctors and other health workers, and then you think, we think that we shall, because we demand pay, so they increase our salary, and then we think that we shall have better outcomes. But
Recording in progress.
fails. So typical models are not linear, as I said before. I'm going to use an example of a patient. And for me, health system strengthening can be compared to what doctors and nurses and others do with patients. Normally, when you are doing, you have a patient, you start by like a correct diagnosis. Even for health system strengthening, you need to diagnose what is the problem and what is the goal that you are trying to focus on. So that's quite important. If you don't have a clear understanding of the problem, of the goal, you are not going to strengthen the health system. But also what is causing this problem. Then a correct
Recording stopped.
A correct intervention package. Like if
Recording
you
in progress.
if you diagnose the patient, you also want to give the right treatment. Until you have the right diagnosis,
Recording
you cannot
stopped.
give the correct treatment. And then sustained and sometimes changing interventions. The minister talked about innovation. Yes, we need to be innovative as we do health system strengthening. Even if for patients, you are doing reviews, you are making sure that they adhere. So the way we treat individuals and we are successful is what we are meant to apply to a system. Do a correct diagnosis, have the right intervention, and continuously innovate to make sure that this innovations are working. When you have the right diagnosis, the right intervention, and you provide it in the right package, then you'll see a dose response. And I think I want to congratulate the minister and the ministry and the partners for all the improvement we've seen in the health system that have been presented today and later in the demographic surveys. Because it shows that we have improved and we can do more. So here is a framework, a simple framework that can be used when we are thinking about health system strengthening. And because of time, I'll not go into the detail, but it says what I've been saying, just like a patient. Step one, make a diagnosis. That diagnosis is with data, with consultation, is with groups, not as individuals. Number two, then based on that, you intervene. Don't intervene in complex systems when you don't have a diagnosis. What is causing the problem? Then as you do, you are constantly, you implement, but as you implement, you actually are using data to find out, is it working? And then you adjust. So just like you do your PDSAs, you can apply the PDSAs as an approach to health systems strengthening. But I think different here, you must learn to use that PDSA approach in delivering packages of interventions. So diagnosis is the starting point, continuous review. I'll give you one example, which the Minister of Health has done with UNICEF and the Gates Foundation and others. And I think now it's such a national planning strategy. The CODES project is where we participated. We are School of Public Health. I was the PI at Makere and working with the ministry and the UNICEF. We started by diagnosis and going the lines. So districts, 8 districts where we started, they would come together and use data. That time they're using LHS, but now they're using DHIS2. But they need to use that DHIS2 better. And now also the DHS, the UDHS, to say how are we performing as a district, as a sub-county, as a parish. Based on that, you plan, then you implement, and you can apply quality improvement to it, and you have health system strengthening. And then reduce mortality. That was the approach. Our work was focusing on ICCM, and we already knew that for ICCM, just training without commodities, without human resource, without physical access, without utilization, without continuous utilization, you will not have impact. This is called the Tanhash model. But the point is, you try to understand what are the things that we need to work on in order to make a difference. What is the current performance? What are the gaps? And based on that, you design interventions. So this was the diagnosis stage. And you go on to ask why are we performing badly? And once you do so, you'll find solutions, and then you can apply interventions. So from problem identification to identifying the cause of the problem, and then to designing intervention. And then the management and leadership becomes critical in designing the intervention that we have identified here. But there are challenges to health system strengthening. One of them is accountability. The minister has actually alluded to this a lot, accountability in the system. Even said we should go and test for HIV and stuff like that, because that is accountability. Then most critical also, the way we use our resources is important. The issue of management, and then critically, and Honorable Minister here is a call to action, the decision space becomes important. If you are going to be designing and innovating and changing, then you should be allowed to be able to make decisions, including use of money, unfortunately, which is critical. So again, just as I summarize, systems are complex. If they are complex, they need very good leadership and management. And this is at all levels. I think my colleague, Professor Lach, presented that especially at the subnational, the health centers, etc., are not performing as well. He said as expected, but I don't think so. I think we need to improve the management and capacity at all levels. And if in the case of hospitals, beyond the director, we also need to is the ward manager trained in management. Do they know what to do? etc. So leadership is important if you are going to manage these complex systems, because they are very dynamic, and we need that capacity at all levels. In terms of management, we require managers in the health system at all levels. Managers plan. So one of the critical things, we need to train people in management to manage complexity so that they can plan, they can organize to implement what they have planned, they can motivate their staff, and they can also measure, control, and see how the system is performing. So one of my call to action is to improve leadership and management at all levels of the health system. Because with good leadership and good management, when they work together in a system, you get improved management systems because there is good management. But also there is a good climate of work environment. For the health workers whose salaries were improved, we need good management system to ensure that they are present, but also a way to motivate them so that we don't use fear to make sure they perform. That will lead to a system that is more responsive and willing to cause change, and it will lead into a system strengthening, and we can have results. So as a final slide, Honourable Minister, just to say that the take-home messages are, I see Dr. Okela, I don't know whether, can I?
To manage ourselves as adults. In the afternoon, there are breakaways, and if what I'm saying is not right, please let me know. The MC, I think, has the best guidance. I may mislead you. So let me invite the MC to say something about what happens after coffee, then when do we have lunch, when do we get back here for plenary in the afternoon, because we must finish what we set aside for today. Thank you very much. Over to MC. Please appreciate the chair for today.
Thank you so much, the session chair. Let's give him another round of applause because he has taken us through the official opening, and I think which is very good. Now, this is just administrative. We are going for coffee, and of course, I don't want to repeat his words. He said we are going to be responsible as adults. But the breakaway sessions are as follows. We have two. this is Ziba Hall. Then we also have Kama Hall, which is just on the other side. So when you look at your program, the Ziba Hall, which is this one, we are going to have leadership and governance. So there are a number of presentations. And of course, Dr. Mugai, he is still on the way. But in the meantime, we have somebody who has agreed to chair that session. Dr. Mary Mudiope, who is the program director of LPHS TB activity, which is a USAID-funded activity, will be chairing that session from Ziba Hall. Then from Kama Hall, we have Dr. Nkoye Abdallah, who is also from LPHS Ankole region, who will be chairing that session. And of course, you will introduce the presenters thereafter. And so we are going for coffee. It's just outside where you registered from. And we are going to come back after 15 minutes. Those of you, you have already made your choices which breakaway session you want to go to. And we shall take, according to, I didn't carry my Swiss watch, but according to the time check, it's 1:45. So we are going to be in those breakaway sessions since we are having a late coffee or tea break. So we shall be in those sessions up to around 1:45. That's when we shall break up for lunch. And further guidance will be provided to you in those guiding places. So our requests, we are going just to allow our guest of honor, the Honorable Minister, of course, and our dignitaries to okay, I've been guided for the tea. The ushers are going to usher you in because it's a small area and this is a big conference. So they will be ushering you in chunks. But the director, you are going to escort the Honorable Minister and of course Commissioner Emergency Health Services and our dignitaries on that table. Okay, I've been further guided that because the leadership and governance, those of you who are going to follow that track will be staying in this hall. And of course, since we are trying to catch up with the time, allow me hand over to the session chair to organize her presenters as others go for tea. So those who are going in Kama Hall, you'll be passing by the tea and then you proceed to that breakaway session. So a good afternoon and you're most welcome. Thank you. Session chair for Ziba Hall. Dr. Mary Mudiope, I hope you're already okay. Yes, she's coming. So, and may I alert the presenters, Dr. Nyeko Philbert, Wangubo Ayub, Naruge Prosi, and Rajala Betty Patian, please be around so that the session chair doesn't struggle very much to look for you. Just be around because your session is starting. So, Mary, you are most welcome, and we are all yours. Thank you.
Good afternoon, everyone. We have been invited for break. Good afternoon, everyone. Thank you. Mary Mudiope, the project director for the USAID Local Partner Health Services TB activity. I'll be taking through the team that is remaining here and has focus on leadership and governance as one of the key building block in the health system. We have 7 presenters. Dr. Nyeko Philbert, I think I saw him around. Is he around? Dr. Nyeko? kindly confirm your availability. We also have Wangubo Ayub from Queen. Ayub, welcome. Naluge Prosi. Naluge Prosi, you are welcome. Do we have Lajara Betty? Welcome. And then Lucia Nakiaga. Kindly join me here.
Let me first put this one a bit down.
They wanted me to start the session. Pick your cup. Pick your cup. Yeah, you're not the first, you're the last. No, so you're among number 3. You pick it. Those that have called out, kindly make sure that you pick your tea, your cup of tea quickly so that we can start the session.
I'm here to present my abstract titled The Impact of Mentorship and Support Supervision to Improve Quality of Health Services in Lagos Sub-Region. Hello, my esteemed co-authors, thank you very much for the work well done. My abstract is in Finke. It is on governance. Introduction.
Unfortunately, many countries, including Uganda, are not on track to reach the sustainable development goal for maternal and newborn mortality. Challenges such as lack of available funds for transport and other health-related expenses, lack of availability of NICU services, and lack of knowledge of when a baby requires additional care result in a number of parents
Colleagues, let's reconverge for our next session. And I want to call upon the presenters to be stepping forward. My name is Dr. Richard Mugahi. I'm introducing myself as the session chair, who is going to take you for this afternoon session. And I would like to invite our presenters to step forward, actually sitting on the front chairs, and then we should be starting shortly. Can we have the chief whip get people back? There are so many behind there. I had requested that they combine lunch and breakfast, but that wasn't possible because it's a quality improvement procedure. In the interest of time, I would like to request that Dr. Nyeko Filbert, Hospital Director Kabale, takes the front seats. Wangobo Ayub, DHO, also one of the presenters, step forward. Naluge Prose is already here. Thank you, Prose. Lajara Betty is not yet here. Is already here. The ladies are really QI sensitive. Amito Janet, quite packed, but if we can have the presenters in front, then I'll definitely allow them to begin. We have 1 hour for 6 presentations, 10 minutes each. So it's going to be the most important message you want us to pick and where you think the change has occurred. I have seen my friend Dr. Nyeko is already here. Those who are standing, please take your seats, or you go and stand outside, but it's okay. But I would request that we take our seats and listen to the first presenter. Dr. Nyeko Filbert is our first presenter, and he will be presenting functionalization of quality improvement structures in the region for improved health outcomes. I expect the technology to be doing the needful, and we don't have much time to spare. Dr. Nyeko Filbert, and let's step forward and make your presentation.
ICT. Thank you very much. Ladies and gentlemen, good afternoon and welcome back from that tea. My name is Nyeko John Filbert, and Hospital Director Kawale. I'll take you through functionalization of quality improvement structures in the region for improved health outcomes. If that is agreeable, I proceed. That red spot at the lowest point of Uganda, left bottom corner in red, is the Kigezi region where we work. Some 410 kilometers southwest of here. We also border DRC and Rwanda thereabout. Enlarging those districts, we are 6 districts there, composed of Kabale, where I sit, Kisoro, Borobanda, Kiga, Rukunjiri, and that's the group of people we serve. The hospital is not so big. Looking at it from above, that's what you'd see. We have about 280 beds congested in a smaller area. It's not actually the capacity. And so far, we have a 66% bed occupancy rate with an average length of stay at 5 days. So we're serving quite a number of people. By way of introduction, I'd like to tell you that yes, we have come here to look at quality improvement. Everybody is doing that. And this particular one, we are interested in how the components of effective implementation of quality care can help us improve. The QI structures serve as mechanism for coordinating 5S, quality improvement, related activity at each level. I mean all health facilities. These structures include the regional QI. We have the regional referral hospital QIs, the district QIs, and the health center QIs. They are abbreviated differently. The thing is not changing. Would you like to shift that slide forward? Yes, the quality improvement requires active and continued support from top leadership. We had somebody present, professor presented and told us about the role of leadership in the QI improvement. In the region, we have especially the leadership at the districts, the chairpersons, the chief administrative officers, the DHOs, the team in the regional hospital headed by the director, and each of these have a key role for us to be able to improve the quality in the region, and therefore must participate in the initiatives. In Kigezi, we have tried to build up these QI structures from health center 2s up to the regional referral hospital level. At the start, our problem was that out of the 6 districts, only 4 had active district QI committees functional. And the regional QI was not doing its role of support supervision and were not being able to perform joint review mission. We had no quarterly district improvement committee meetings, and we had assessments, and we also had limited initiative at the regional referral hospital to discuss the regional health. And therefore, we had to conform to what the national level says, that we should be holding support supervision and regional quality improvement. In the process, we had to get around those problems. As I said, they were there. The few functional district QIs, we had no support supervision, we had no joint review mission going on, and we had no quarterly district QI assessments, and so very little initiative. We had to identify stakeholders for the regional QI committees. We designed and issued appointment letters for the regional members. We also mobilize funds for convening regional QI committee meetings and the regional joint performance review missions. We identified and trained district QI focal persons, developed work plans for the regional QI committees and the district QI committees. We had quarterly assessments of regional QI structures, and we also went out to benchmark and see how it is done elsewhere. After doing that, that's what we came up with. At the end of the day, as I speak, by today as I speak, we have all the district QI committees functional. We have 90% of the regional QI committees in functionality as of Q3 last year. And then we have the district QI committees assessment being conducted at least in 50% of the cases. All our districts now have the district QI committee work plans. Ladies and gentlemen, from that little approach, we can see that there has been progressive improvement in the regional QI committee assessments, rising from 85, and now we are at about 90. We think we could do better, but we also have other system issues that are tying us down. The district QI assessments, or QI committee assessments, were also done, and if you look at it carefully, we are not yet there, but most of us are scoring above 50, and that means we are progressing and we are doing fairly well. During our GRM, one of the biggest problems we got was with assessment of TB at OPD. We embarked on this, and in the process, we can also see that we improved in that. And most importantly, and perhaps what you need to see, is we are serious and we would like to have our gene expert utilized. Do we go anywhere? Yes. The ranking of the league so far has enabled us that because of this initiative, we have at every one time 3 of our districts in the top 20 of our league. And at any one time, we will have at least one district either being number 1, number 2. Notably, we initially dropped in the average performance as a region at the national level, but over time we are picking up and our districts are doing fairly well. We think we should be improving. That picture shows Rubanda district receiving a recognition just last year for being one of the best performing districts in the country. Because of those initiatives, we also managed to hold our maiden regional joint performance review mission for Kigezi. It was attended by more than 350 stakeholders, and we developed an aid memoir that was circulated. Some of you may have seen it, and I think the full report should also be getting into the circulation. Those are the pictorials. I want you to lower your eyes to the lower right-hand corner picture. That was our keynote address by Professor Tumwine, and he gave us how to eat healthy and not to have medicine for food. We have not stopped. We continue to have our quests for regionalization of our QI by going out to benchmark. We have visited many other places, and we have tried to borrow leaves from other places which are doing fairly well in some aspects so that we can improve what we have. We have been to Gulu and Elira, looking at how the regional parliament is performed and how it could help us improve. Bringing the various stakeholders in the regions to participate more closely in the governance and management of healthcare services in the region. We have also brought on board the university. We have Kabale University, and there is a faculty of medicine. Now that they have come to our hospital, we would like to work with them to improve patient care. And this will be best done if, just 1 minute, if we know how to collaborate and coexist. Ladies and gentlemen, all I've said in those few minutes is that resource mobilization, coordination and identification of key stakeholders is crucial in ensuring functional regional QI and hence improving quality of healthcare outcome in our region. I want to thank you.
Big round of applause for Dr. Nyeko. Thank you so much. I beg that you can take your seat, but you'll keep the questions and comments. They'll be welcome at the end of all the presenters. Our second presenter is Wangubo Ayub. I don't know if the right pronunciation. Application of PDSA model to functionalize quality improvement coordination structures, the lessons from Kweni. Let's join him to welcome our presenter. You have 10 minutes, sir. Thank you.
Thank you very much, Chair. Good afternoon, ladies and gentlemen. My name is Dr. Wangubo Ayub, the District Health Officer, Kwen. And I'm here to present the application of PDSA model to functionalize quality improvement coordination structures. What we do best in Kwen to ensure that these structures are functional. IT. Okay, like I said, those are my names and those are my co-authors. Yeah, Kwen District is one of those districts found in Sebei sub-region in the eastern part of Uganda, and those are the bordering districts. We have 24 health facilities, 20 of them are government and 4 are PNFPs. 1 health center 4, 10 health center 3s, and 13 health center 2s. Kwen District is generally mountainous. It has 3 belts. We have the flatland, we have the middle belt, like a plateau, and then the highland. That is the geographical map showing the bordering districts. So, way back in 2015, MOH with partners set up guidelines on how to operationalize and functionalize those coordination structures at national, district, and health facility level. But since then, majority of these structures have remained non-functional. Of course, Kwen was not spared. So by 2022, we barely had a functional district QI team, but at least we had some few facilities that had some functional facility-based QI teams, courtesy of the implementing factors. So we set out to see how best we can improve or functionalize these structures. To functionalize the district QI team, and then functionalize the rest of the other facility-based QI structures. So I and my team, the DHTs, sat down, brainstormed to find out what exactly could be the root cause of the non-functionality of these structures. And we realized, or we found out that there were majorly 3 factors that was contributing to this non-functionality. One of them was knowledge gap and QI principle, the health facility teams, the health workers, and then a majority of the leaders. We also barely had any kind of supervision for the QI initiatives in the various health facilities. Then, of course, we took QI as a partner thing. QI it was a partner thing, so we never prioritized it as one of the strategies through which we can improve quality of services. So what are the test changes that we employed to see that we functionalize these structures? Of course, the knowledge gap, we had to build capacity through our partners and then the regional QI team. Mbale regional QI team, it was vibrant and functional, so it did quite a lot to ensure that it supports us in building capacity. Then the supervision bit of it, we had to come up with the mechanisms of supervising and monitoring QI initiatives, both at the district and then the health facilities. So we had a team with clear terms of references to govern their activities when it comes to monitoring and evaluation. Then that mindset change of laissez-faire, not caring about QI, we had to adopt this QI initiative as one of the performance indicators to the in-charges. Other than the other core roles, we also adopted QI initiatives as one of the assessment indicators at the end of every quarter. So these initiatives ran from July 2022 up to June 2023, and that is how the progress was. When we started in that last quarter, that's when we did the baseline of evaluating ourselves as far as QI is concerned. Like I said, we barely had a district QI team, so we didn't have it in place, but we had some few facilities that had. The first quarter of 2022, there was some increase. So there was a progressive increase, in other words. So if we draw attention to this line graph, when we did the orientation of the DHTs and health facility in charges and quality of care, that framework and the principles, we noticed some gradual slight changes, but it stagnated around Q2, October, December. Then Jan, March, we again had to employ another mechanism of fostering, because now we knew that these guys know what they are supposed to do. So we had to employ other mechanisms in which we can ensure that all the facilities have vibrant and functional quality. So we had to now bring on board the QI initiative as one of the performance indicators, and this helped us a lot to ensure that most of the facilities had a vibrant or functional teams. So what do we learn from that?
You have 2 minutes.
Improvement was attributed to compulsion of health facility in charges to prioritize QI as a regular monitoring and evaluation initiative. However, you realize that we did not score the 100% that we needed because of the other nitty-gritties, that the measures for you to qualify for a fully functional QI team has a number of parameters, some of which we were unable to attain due to logistics management, like having regular shared learning meetings. Were unable to conduct those ones, so we could not hit the 100%, but nevertheless we were able to drive it from 0 up to around 91%. So conclusions, lessons learned: knowledge gap, negative attitudes towards use of CQI are major contributing factors for failed functionalities of health facility QI teams. And then funding QI activities, consolidating teamwork, and addressing negative mindset towards QI activities improved QI functionalities in Kwen district. Thank you very much. Great thanks goes to our partners, Baylor, Ministry of Health, and Mbale Regional QI team. Thank you.
Big hand of applause for Ayub. Thank you so much. You actually used your time very well. And now take the honor to invite Ms. Prose Nalwege to make a presentation on improving proportion of facilities with functional QI committees in Mbale district. Prose, you're welcome. You have 10 minutes. I will alert you at 8 minutes. Thank you.
Thank you so much, Chair. Ladies and gentlemen, protocol observed, good afternoon. My name is Naluge Prosi. I'm a senior clinical officer. I work with Mbale district. I am also the district QI focal person for the district, but I as well support the region in quality improvement work. I'm here to share with you our progress towards the journey to improving functionality of QI in the different levels under Mbale district. It's entitled Improving Proportion of Facilities with Functional Quality Improvement Committees, with the support of authors, but most importantly, the support given to us by our DHO, Dr. Wangisi Jonathan. The authors acknowledge that QI is a key aspect of service delivery and institutionalizing quality improvement approaches at the different levels of health service delivery. Ministry of Health, in its QI framework that we use as guide, that is 2021-2025, one of its aims is to improve leadership, management, accountability at all levels of healthcare delivery. Through our evaluation as DICO Mbale, we revealed that only 12%, that is a proportion of 2 out of 17 facilities under our support, had functional QI committees. And we had defined functionality as having at least one journal running, having a fully constituted QI committee, having at least an action plan in the recent past, having implemented 5S, at least to a tune of only the first 2, that is the sort and the set. That was our measure of functionality. A project then was instituted that aimed at improving functional QI committees in terms of proportion from a tune of 12% as of January 2023, I beg your pardon, to 100% in a time span of 8 months. What tool did we use? We used a commonly used QI tool that was a fishbone to be able to explore the root causes to such a huge gap that we had in terms of functionalizing QI in our level 3s and level 4. When we used 5Y, we combined it together with, when we used the fishbone, we combined together with 5Ys to be able to understand exactly where the root causes were embedded. We noted with great concern that the DICO committee members themselves had issues of understanding and actually how to execute their different roles at the lower levels that they're supposed to supervise and mentor. We also noted that one of the other root causes, the facility leadership at the different levels of structure had issues in understanding and also understanding how to integrate the QI work plan in their usual budgets. We also noted that 5 out of the 17 health facilities had QI teams that had no QI committees, and the 10 out of 17 had incomplete teams, and only 2 health facilities in the entire district had a complete functional QI committee. We also noted that routine QI supervision were actually undetermined. There were imbalances in terms of adaptation and implementation of QI activities across facilities. We noted that some facilities would actually be implementing QI at almost all the parameters of our measures, but a bigger proportion had almost no parameter that they were actually fulfilling. What did we do differently? An orientation of the DICO was our very first step to take on their roles, and also taking them through the basics such that they can be able to understand basics of how to open up a journal, basics of how to support facilities to come up with problems that are actually affecting the different indicators of priority in our district. And our guide that we used then was the recent 2021-25 QI framework. This we do in each and every meeting that we hold every quarter to remind members, the DICO members, of their roles. We sent out letters of assignment that had been signed off by our cow district in Bale district. The facility in charges and their QI focal persons were then co-opted on the DICO committee. When we co-opted the DICO committee, when you co-opted the in-charges and their QI focal persons of the facilities on the DICO, this took us a long way in holding them timely before their chairperson, that is the DHO, in terms of how much they have supported QI work in their facilities. And in all our quarterly meetings, the in-charges and their QI focal persons come with their files as a form of accountability, and they are supposed to share what far they have done in terms of executing the QI activities in their facilities. But also additionally, this has had them being held in terms of integrating their budgets with a bit of QI work, but specifically having a token going towards the meetings that are supposed to be held monthly in their facilities. And also, in my district, no work plans are passed by my DHO to higher authorities without a component of QI being integrated in the budget. Later on, we formulated a facility QI teams as per structure, because this was also wanting facilities had incomplete teams that were not in alignment with the QI structure. Each clinical mentor that sits on our DICO committee was then given a responsibility of overseeing facilities as a way of having a bit of accountability when they come in our DICO meetings. They are supposed to do support on a monthly routine, courtesy of our implementing partners that at times offer us support in terms of vehicles and fuel and an SDA to those members that move out to facilities. A QI district WhatsApp group was also created, and this platform has given us a better way to discuss timely what has worked in the different facilities, share challenges, mobilize the members, and so many other things. In that run chart, what we see is a journey how we struggled right from January to our current status as of 2024. November, January was our baseline. Wanted us to appreciate the problem that had actually been on for a long time. And from the 12% baseline of January 2023, we see ourselves sail progressively to a tune of about 88% in a span of about 6 to 8 months. And some of the things that worked tremendously well was allocation of a budget allocation, but also having our in-charges being held responsible in the DICO meetings when they come to be part of the DICO members. Attachment of the QI coaches to specific facilities helps us keep track of the implementation work in the different facilities. In that picture, we see our chairperson, DHO, chairing one of our DCO meetings. That seems to be, it looks very fresh. It was in our very recent meeting for December, October. What have we been able to see? With those changes being implemented, we've been able to note that 100% of facilities in our Mbale district are having fully constituted care committees. 100% of our sites are able to sit at least monthly because they have a budget allocation by the leadership at those levels. 100% at least have a journal being monitored in the indicators of priority nationally. And 100% are now able to allocate some funds for care activities like meetings at facilities, and also 80% of facilities are having evidence of 5S, this time up to a tune of SHINE, which is a good trend of progress. In our discussion, we note that quality improvement is an imperative undertaking essential for enhancing effectiveness and safety of health care delivery in all levels of care. Through assessment and targeted interventions and monitoring, facilities can be able to identify their own performance gaps, can be able to be supported to come up with innovations within their means that are evidence-based. What we learned from this sharing, that simple and low-cost initiative produce
2 minutes.
Great results when leadership and coordination is addressed. In conclusion, co-opting in charges and their care focal persons onto DCO has improved accountability very timely on a quarterly basis. WhatsApp platforms is a very reliable, very cheap way of communicating and sharing learnings of quality improvement. In our recommendation, we recommend that quick adaptation and continuity of quality improvement is very paramount to involve leadership at all levels of service delivery at all facility care levels. I want to acknowledge support from our dear DHO, Dr. Wangis Jonathan, for having us sail through this journey of improving functionality, but also our implementing partners, Baylor and UHA. We are indeed indebted to you. Thank you so much for listening.
Thank you, Prose and Team Mbale. Jonathan, thank you for leading your team and giving them money. As I mentioned earlier on, we just need to keep our questions and comments. And now allow me to invite the fourth presenter, Madam Miss Betty Lajara, who is going to present on the implementation of real-time and periodic client feedback systems to improve facility responsiveness to client care concerns at St. Mary's Hospital, Acho. Betty, you're welcome.
Thank you. Yes, I'm called Betty Lajara, Principal Nursing Officer, Quality Assurance Focal Person, St. Mary's Hospital, Acho. Just like it's mentioned, we looked at implementation of real-time and periodic client feedback system to improve quality, facility improve responsiveness to client care concerns at the hospital. This initiative was fully supported by the leaders of Lacho Hospital and AFSI. Sorry for that. So Lacho Hospital is a referral hospital that serves about 250,000 patients annually. And on a daily basis in our outpatient, we see about 270 patients generally. And looking at this number of high turnover of patients, we notice that without quality improvement, we cannot serve our patients to their satisfaction. So this one brought us to think, because this huge number of patients, they always have their concerns that bring us around the hospital. So it gave us thoughts of how do we make sure they go out when they are satisfied. So we embarked on this real-time client feedback system that is aimed at gathering and filtering the message, the concerns that these patients bring for us, so that we improved on their services. And when we say real-time, we want to tackle it immediately as they come, and the periodic, which we focus on. So what did we do? We introduced this feedback system, which was set up at personalized outreach points. Initially we had only suggestion boxes around the hospital that we were opening it not quite often, but after like 6 months. But we thought that was not enough to take care of our clients. So we introduced emails. We opened our email free for people to communicate, phone calls, and then text messages. We also introduced social media, which focus on WhatsApp, Facebook, and Twitter. And this, additionally, at our outpatient points, we introduce client feedback books that whenever a client comes to the facility, they are actually encouraged, they are introduced at the beginning to comment and to write for us something that we need to change, something that we need to improve on, and then at the same time, if you have positive concerns, they are all written there. And this, I think I'm not, please. Yes, this system was enforced with introduction of constant communication office, which in previous years we didn't have. Now we have a fully functional communication office with a communication officer, and with our functional QI committee at hospital level and departmental level, we co-opted all the teams and we gather all this information, and they are discussed at outpatient on their daily review and in their monthly meetings. And then at the same time, we look at the suggestion boxes that we have. We review them every month in our QI committee meeting. So responsive actions were tailored to clients' concern, and then we summarize them. After our meetings, we actually send this to our management for intervention. So from July 2020 to June 2023, the implementation system yield actually tangible positive outcomes. It enhanced hospital image, and because in most cases we were receiving very many concerns from our clients right in the corridors of the hospital at the same time through social medias. So we got a lot of feedback, and very many people were giving us this feedback. We actually welcomed them positively. So the hospital social media following, particularly on Twitter, experienced a substantial growth of up to 78. And the client feedback include challenges, which are common things. Unless you listen to a client, unless you give them time to explain to you, you won't understand them, and they go back when they're not satisfied. Among them, we had prolonged waiting time, which is very obvious, and client computer system slowed down, because in our outpatient, we introduced the computer system in the pharmacy, in the outpatient, at the same time in the laboratory. So sometimes these systems can fail us. And then we had instances of staff rudeness, which actually was very common, and some drugs not available. There are some drugs that are not in the hospital formulary, and sometimes when we stock them, they take long, and patients were not happy. Why should we not have these drugs? But usually we direct them. So client feedback highlighted humane care and quality investigation and treatment available. So among these, we also noticed that most of these concerns comes as a result of failure to communicate well. If you don't communicate well to a client on where they are supposed to go, you cannot actually satisfy them. So with constant communication to these clients, we actually help them and they understood us really very well. Next slide. These are all feedback that we captured from our client. Next.
2 minutes.
So this project result highlights the profound impact of timely response of our clients, and it actually elevated both standards and overall experience of clients. As we continue to have this feedback, we notice a reduced dissatisfaction from our clients, and at the same time we had very good positive feedback from them up to now that we are talking. We acknowledge the realistic and well-intentioned nature of many patients' concerns, which we address, and the authors actually address the intrinsic overwhelming healthcare challenges. For us, the healthcare workers, they think if you listen to a client, you are being biased on them. And most majority of staff do not take getting clients' feedback as important. And they thought we are listening more to the client and neglecting them. And yet we feel if you listen to the client and you listen to the staff, we come up to a compromise, and it reduces bias to both parties. So the dedicated commitment of staff, because when we have this, we actually gave opportunity for our clients to mention names, which sometimes people may think is actually not ideal. In our hospital, we have uniforms that have staff name. So we encourage our clients to mention names, and these names actually help us to deal with individuals. So noting that a client will mention your name whenever there is an issue, will really encourage you to do better than you can do. So it helps us to address critical issues that help to improve also on the outlook of the hospital and general quality of services. Next. So these results affirm purposeful management interventions to seek and respond to clients' concerns, not only attainable but yield commendable results. It also manifested improved client experience and constructive staff correctiveness, as I have explained. The results underscores informative influence of proactive measures on the hospital's image, and then advocating for an ongoing commitment to addressing clients' feedback. Next. So what did we learn from this? We are saying real-time responses to clients' concern emphasizes potential of this response in shaping an individual. It also shapes the impression of people on an institution.
Summarize.
Yes, 1 minute. And then now we look at correct actions culminating positive outcome for both the client and the patient. We are saying positive or negative, a feedback is very important. And client feedback can be used for quality improvement. And we always say, quality begins from you and me. If I don't embrace quality, if an individual doesn't embrace quality, we shall never achieve quality. So let me take this opportunity to say thank you.
Put our hands together to appreciate Betty.
Of AFC and then the management of Lacho Hospital. Thank you so much.
Thank you, Betty. Thank you, Lacho, Team Lacho. And we shall reserve our comments and questions. Allow me invite the second last presenter, and I've reduced their time to 8 minutes, and that is Lucia Nachigi. Lucia will be presenting to us improving client satisfaction for women screening for cervical cancer. Lucia, you're welcome. IT, please project.
Thank you, moderator. Very good afternoon to us all. Once again, I am Lucia Nachiega Wamala, and I work with Macquarie University Walter Reed Project as a Quality Improvement Technical Advisor. As earlier hinted, I'll be presenting on how to improve client satisfaction for cervical cancer screening, and this is majorly findings and feedback from what we did. So in July 2023, the New Vision wrote an article, and they were highlighting how women are coerced for cervical cancer screening services, and on the spot was Mukono General Hospital, which is one of the facilities that we get to support. And as an implementing partner that supports this hospital and several other hospitals and health facilities in Mukono district, in Mukono, Kayonga, Buvuma, Boyikwe, and currently we also have Luwera and Nakasongola, we set out to ascertain the level of satisfaction of women with the cervical cancer screening services. We also wanted to see and appreciate the quality of the cancer screening services, and also determine the factors that are influencing cervical cancer screening satisfaction. And we needed feedback from the clients on the clients that are screened. We needed to get their experience, their perception of quality, willingness to recommend cancer screening to any other woman out there within 25 to 49 years, but most importantly, we were interested in their overall level of satisfaction. And the methods that we got to use, looking at the proportion ever screened, we focused majorly on Mukono General Hospital, as earlier highlighted. This hospital had a total of 3,448 women by July 2023. And of these, we had 2,437 had been screened for cervical cancer, and that gives us a proportion of about 71% of the women had been screened. And we definitely sat back and realized that we would be having a few limitations to this survey, and some of these were regarding sample size consideration, given that we needed to really ascertain the satisfaction, but within a short period of time with limited resources. We only reached out to 50 women, which is only 2% of the women that were ever screened. But to allay our fears, we'll be able to see that at least the confidence level we arrived at was quite good to give a good representation of the findings we are going to share. And also, the other limitation is around recall bias on the service quality and the experiences, especially for women that had been screened months ago. Sample size estimation, we use the RMNCAH formula for sample size estimation. And as we get to see, our confidence level was 90%. And this is majorly in summary to say that at least for the sample that we got, we would 90%, it would have a good representation of about 90% of the women that had ever been screened. And putting the proportion that we had, the sample, into our formula, we were meant to reach out and interview 56 women. We used the purposive sampling method from women that were awaiting refills at the facility for about 3 to 4 different clinic days. And we had a very good response rate of 100%. And we administered a client satisfaction survey that was translated in the local language, and majority of the clients speak Luganda. So this was translated to Luganda, and we were able to interview a total of 50 women. Our first bit of the results, we were able to see some of the clients that responded yes to the different service domains. And I'll first focus on the domains that had over 80%. What really stood out was privacy and dignity respected. We see that 98% of the clients that we got to interact with appreciated that their dignity was respected. They encountered privacy while being screened for cervical cancer. And we also got to appreciate that a good percentage, 84%, were aware of cervical cancer screening services. And then we see 83% of the women, especially those that had been, those that needed treatment or those that needed thermocoagulation, had received follow-up. And then we see some of the other areas that were fairly, women responded yes, but it was at least below 70%. We see that about 60% of the women that had been screened responded that they were able to receive a bit of counseling and education. And then about 72% were involved in decision making, which we found fairly okay. But very key for us is where we see the red score of only 38% of the women said that they had seen IEC materials, which leaves us with the other balance of about 62%, wondering why they were not able to look at any visuals concerning cervical cancer screening. So we go to the right, where we see clients' perception of healthcare worker service delivery and the screening environment. The first three bars are majorly looking at the healthcare worker service delivery, and then the last one is looking at screening environment. And we majorly did poorly here regarding health workers, the ability to bring clarity on why the patient is getting screened. We saw that about 44% ranked poor for this particular domain. We had rankings from excellent, very good, good, fair, and poor. And particularly in regards to being able to give clear information, about 44% did not get this information. However, all the other domains, looking at quality of care, we had over 80% acknowledging it was good, excellent. And then when we come to friendliness of the health workers and empathy, we had also over 80%. We see 17% were excellent, 27% very good, 44% good, and only about 12% said it was just fair. Empathy was only fair. And then where we did best was regarding cleanliness and majorly cleanliness of the examination room and how convenient it was. We see that the key feedback and ranking was majorly from good ranking upwards to excellent. And going on to the other results, we're able to see how likely were the patients able to recommend cervical cancer screening, those that had been screened before. Overall, we see that 98% of the women living with HIV between 25 to 49 years were willing and ready and open to recommend cervical cancer screening to their counterparts, and only 2% were neutral. And when we get to look at overall satisfaction with the cancer screening services that were received, we see that close to 90% of the women were either satisfied or very satisfied, with 16% very satisfied and 74% just satisfied. And we have a 2% that were not sure, and we have the other, about 8%, that were not satisfied. That's 8%. And going on to, I just want us to see those that were not satisfied or those that would probably not recommend cancer screening services. What were some of the issues? Maybe just to take us back to the very first slide, what triggered us was the feedback from New Vision. Just to take us back to the first slide, and we really needed to find out the feedback from the clients that we're working on. So we have 5 clients that were not satisfied, and we're able to see the different reasons. I may not read all in the interest of time, but just to pick out 2 of them, some of them, one of them was not satisfied because they were not given screening results. Another was not satisfied because they feel they needed more health education regarding screening and or preventive measures. And then looking at the overall recommendation, at least from all the clients that had been screened, they span from maintaining all that is being done and then being able to provide more health information, quite a number of recommendations. And I just want to take us back to this particular slide that I had skipped. And this is majorly focusing on some of the, when we did the analysis, just to see the associations, what are some of those things that will trigger satisfaction? Is it age? Is it level of education? Is it marital status? And we were able to see, because we had a number of variables that we got to compare with level of satisfaction, we used a Pearson chi-square test, and we saw that only 3 variables were significant with a level of satisfaction, and that was age. It had a positive correlation. So older women were more satisfied with the cervical cancer screening services. And then we also saw that quality of care received. We left quality of care open to the judgment of the client. And then the lastly was on willingness and ability to recommend. And finally, to conclude this, as we conclude key recommendations, we see that it is very important for us to empower the older women, especially as champions for cervical cancer screening, to inspire and encourage the younger women, since we saw a very good positive association. And then it's also key and important for us to increase awareness for cervical cancer, for HPV vaccination, awareness and availability at our health facilities, especially at health center falls and above. And then it's also very key to improve referral pathways, especially for women that get to have abnormal screening results, since we saw this as some of the recommendation on improving the quality of care. But I know this is not only unique for General Hospital. And it's also key, as we saw that the quality of care had a positive association with a level of satisfaction. It's very key and important for us to sustain the quality of care, because it gets to meet the needs of our clients, and not to say, given that it's one of the key principles of quality improvement. Thank you so much. That is
a big round of applause for Lucia, and we appreciate you and your entire team, Morap, for this great work. Our last presenter is Jeanette Amito. Jeanette will be presenting to us. We can clap for her. Jeanette will be presenting to us quality improvement initiatives to improve participation of clinicians in functionalization of QI structures and implementation of QI initiatives in Lamo. Jeanette, you're welcome.
Good afternoon. My name's Janet Amito. I work in Lamo District Local Government. Lamo is one of the districts in northern Uganda under Gulu region. I'm an assistant nursing officer. As our topic of today, I'm presenting improving participation of clinicians in functionalization of QI committees and implementation of QI initiatives at Lamo District Local Government. As we are all aware, today everyone was talking about innovations, improving participations of our health workers, clinicians. So as a district, we innovated in a way that everybody who works at the healthcare participates in quality improvement. Because if not everybody is on board, we shall not achieve what the Ministry of Health and the district needs. So as we can see, as a district, the Ministry of Health recommends that at least at health center 4 and health center 3 level, there should be 100% of functional quality improvement programs. And as a district, we identified there were some gaps. That's why we came up with this innovation to improve the functionalization of participation in LAMOA. So one of our key gaps that we identified was knowledge gaps by the clinicians on quality improvement initiatives. There are a number of areas that as a clinician, as a healthcare worker, you need to know in order for you to improve and participate in quality improvement. There was also lack of internal and external support supervision. Here, as we heard in the morning, in order for us to improve on the quality improvement initiatives, there should be supervision happening in the facilities, both internally and externally. We also identified that there was poor system in place to reward and sanction the best and poor performing clinicians. In this way, as it was spoken by one of the presenters, if everybody knows their roles, and if I know that if I do well, I will be rewarded. If I don't do well, I will be sanctioned. In this way, the system will improve, and quality improvement initiatives will also be by the different groups who are working at the health facility. What did we do as a district? As a district, we conducted health facility quality improvement baseline orientation on key areas targeting all clinicians. I know some of us are wondering who are these clinicians, because at facility level, nurses, we have midwives, we have clinic officers, we have medical officers. All these ones are involved. We are not meaning only the doctors or the clinic officers. Nurses and midwives are also clinicians, because if the medical officers are not around, they take over that system at facilities. So everybody has been oriented on the key areas. Secondly, we also conducted the quarterly clinician-led inter-facility learning sessions to improve on the knowledge of some of the clinicians who didn't know what were those quality improvement initiatives. We also had a baseline assessment on 5S. As we heard, 5S is a key to quality improvement implementation. And we introduced the baseline 5S to the clinicians. We were also giving feedback on quality improvement functionality and 5S implementation progress. Because for somebody to know that they are working or they're involved, you need to give them the results. As we took them through, we gave them the baseline orientation, conducted the clinician-led facility learning sessions. We are supposed to also give them feedback on how they are doing or improving on the quality improvement initiative and also 5S progress. We have also integrated quality improvement into the routine support supervision because we know that as a district we conduct monthly, quarterly support supervision in all health facilities, especially Center 3s and 4s. So we, as a district, we made it a point that quality improvement needs to be integrated into the routine. Whatever you go to implement, to see at the facilities, you need to put quality improvement. You need to look at the 5S. As we heard the minister talked in the morning, that she almost entered under the table to see where 5S is. So if you don't improve or integrate the 5S, if you go to facility, you don't look at the projects that they are implementing, you will not know whether the quality improvement initiatives are being implemented at those levels. So these are the results that we have seen from April of 2022. That's the time that we started implementing this activity. As a district, we were only at 23% of clinicians participating in the quality improvement initiatives.
After introducing those changes, as a district, we have been able to move, as we can see, from 23% in April of 2022 to 2023 April, we have been at 76%. And currently, the facilities and the district are still implementing those initiatives that were introduced to them to improve and make quality improvement part of them, so that we don't withdraw. As the partner also withdraws, the district staff also withdraw. For the district, we are continuing and we are still doing the needful. Next. As a lesson that the district has learned, we have seen that if we engaged all the district structures, we create awareness through meetings, through learning sessions, and integrated support supervision. Those areas are critical for us to improve and also interest the participation of the clinicians in quality improvement initiatives. And in conclusion, quality improvement initiatives and programs can be improved when all the clinicians are involved, coupled with skills and knowledge that you empower or you give to the various clinicians. If everybody has the information and the knowledge, they will be able to improve on the quality improvement and the quality of service that they offer to each and every client and patient that come to the health facility. Thank you.
A big round of applause for Janet. And Janet, just remain seated in front there. I don't know if you'll make it.
Okay.
Is that comfortable for you?
It's okay.
I'm kindly requesting that we get very quickly all the presenters and one question each. That will be enough appetizer for your lunch. Dr. Philbert Nyeko, guide your team. Step forward. You have enough seats in front. Lucia. And now I'm moving the mic for 6 questions. 6 hands. The questions might be slightly more, but 6 hands. But I want to limit 1 question per person. At most a comment and a question. If you had 2 questions, turn 1 into a comment. Yes. Here, 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay, times 2. Can someone move the mic? Number 1 is here, around here. It's only 1 microphone.
Good afternoon. My question goes to Betty. I would like to know the trick they used to reduce computer breakdowns or shutdowns or slowdowns, because we are facing that challenge. Thank you so much.
Thank you so much for enriching me, all the presenters. Thank you so much. I have only 2 concerns. One is about quantifying. Whereas this concern is for all the presenters, I would wish the presenter Ayub from Queen to represent all the presenters. I want to cite an example of supervision. When you said there was inadequate supervision, did you mean there was inadequate in terms of frequency or in terms of the content? When you say inadequate, what do you mean? Just help me on that. Then the other thing related to that is that you did interventions. Of those interventions, is it easy to cite out which ones worked and maybe to what extent they worked? So that's about quantifying that I want clarification. The other one specifically goes to Lucia. When I read the title, it was about improving satisfaction. So following the conversation, the presentation, it appeared more of an assessment. Did I get it right, or it was more of finding out the levels of satisfaction? How do I connect it to the title? Thank you very much.
Thank you. Thank you very much. Station Chair. My name is Moses.
Oh, we can't hear you.
Oh, the microphone's not function.
Second microphone.
Thank you very much, Session Chair. My name is Moses Balina. I am a public health specialist working with Maldima Uganda. And my question goes to Dr. Nyeko. Thank you very much for the great work in the region. Now, the Director, Regional Referral Hospital, being a healthcare worker, possibly understands quality improvement more than a Chief Administrative Officer. Now, it comes that the cow is the person who appraises the DHO, who is the chairperson of the DICO. What has been the role of the Chief Administrative Officers in functionalizing the DICOs in your region? Thank you very much.
Thank you very much. My name is Peter Okelo-Deke from Lira. Just cutting across. One, there is usually this challenge where people who have worked in a facility for a long time, when you come with some innovations, you begin saying you came, got us here, and you leave us here. But I think call it basangwa, something like that. Somebody knows better the right word. What has been the key challenge we have all met as presenters in this area, done innovations, relating to those kind of staff who have that attitude towards the innovations? Two, if allowed, is also that, especially for Mukono, there is usually this urban-rural setting, and the competition. I'm trying to bring the issue of having the private clinics against the established facilities. Now, when you're looking at client satisfaction, did you try to interrogate what comes from the clinics as compared to the public institutions, given that there is always that thinking that government or public institutions, the services are general, not what? Okay, thank you.
Thank you. Thank you. I'm Sandra. My question goes to Betty regarding client feedback. How did you ensure client privacy and non-disclosure of this, sorry, of these clients? For example, how did you ensure that the clients were protected from staff exploitation? If they give you their information, how do you protect them from exploitation from staff? And when this health worker knows that this client gave a bad report on me, how do you ensure that the clients are protected? Thank you.
Thank you very much, all the presenters. I'm Stephen Chigongo from PMI Uganda Malaria Reduction Activity. My question goes to Betty Lajala. I wanted to ask, what percentage of the issues from routine feedback was actually most prevalent? And what percentage were we able to address comfortably during this real-time feedback? Did you notice any decline as we moved along the course of time? Because we would have loved to see such visuals in your present out. Thank you very much.
afternoon. Thank you to all the presenters. My name is Salma, QI officer from IDI. This goes to you, Betty. I think you've gotten quite a number of questions, but I'll ask it anyway. I realized that in your results section, you did not give us exactly the quantities. I think that's been going around from everyone. But it would be important for us who want to go and, apply these principles in our respective contexts to know what are the characteristics of the people that, you got responses from. What are their literacy levels, the characteristics, their age, because many of the facilities out there state that they do not do client feedback because, they're using suggestion boxes. The clients can't write their literacy levels. And you mentioned positive outcomes. It would be very, very important for us to quantify that. You mentioned it's many people who responded. It would be good for us to know how many people responded per, mode of communication that you used. Thank you very much.
There are two hands in front here. One of our...
Thank you so much. My name is Rebecca Nachimuli from Kiwa Municipal Council. I really appreciate the first three presenters. Actually, I came to learn lessons in functionality of QI committees. My question goes to Queenie. I wanted more clarification on what was the numerator and denominator in the assessment of the DICO when we are talking about one district, which is Queenie. Unlike with Dr. Nyeko, where we had 6 districts, for the presenter in Queenie was addressing one district, but was rating it the same way the 6 were rated. I wanted to know how was that one district assessed. Thank you.
Yeah, thank you very much. This is Amoding Salme. I come from Moroto district. I had also a concern to Sister Betty from Lacho. For a scenario of Moroto, when we do client satisfaction, there are those ones who are not learned, there are those ones who don't know how to read, and according to the scenario of Lacho, the client satisfaction, you are using WhatsApp, you are using Twitter, you are using what? So for us in Moroto, we don't have those who know how to read and write, and on top of that, they don't have phones. So how have you taken care of those? Then the other question goes to DHO. When I was like, that graph was staggering, like it was flowing at the same levels. And in that, in my mind, I asked, could it be because you introduced so many tested changes at the same time, and that's why the graph was just moving at the same pace? It was not really yielding fruits where you could see that at least this one change I've introduced that has worked out. So I also needed some clarifications on that. Thank you so much.
Hi, yes, my name is Jessica Healy from USAID. This is an open question, and I understand this panel was on leadership and governance and systems and customer satisfaction. I was just curious if any of you had major health outcome results that, that you really identified through these, but maybe didn't have a chance to present, that you could share with us, or any kind of significant systems improvement that came out of the improved governance or feedback. But thank you very much for all the great presentations.
Thank you. I'm called Esther Nkolo with USAID. My question is to the district representative, but I think I'll direct it to Janet of Lamour. I'm interested in the district processes for prioritizing QI improvement aims. What do you go through to decide, and how do you manage the influx of priorities from national level? You get priorities from TB, maternal, newborn, HIV, and so on. As a district, how do you support the facilities and communities to choose what they can manage in a specific period. Thank you.
Chair. Chair, a quick one.
Oh, yes.
Thank you very much. I want to appreciate all the presenters. Martin Sendiona from the Ministry of Health. Client satisfaction is everybody is becoming increasingly interested. And what I wanted to really emphasize that we need to institutionalize this, to have it being done more frequently and routinely, and then address the issues as the presenters have done so. My quick question is, if they are incurring any challenges on the cost, or they have a small budget for it, they may wish to share with us, and we know the implication of that. Then the second one is maybe an advice. I think we may not need to mention names when we are implementing client satisfaction, as it was mentioned by one of the presenters, because this is done in good faith and good purpose to improve quality of care. When you start, mentioning names, people will feel victimized, and it may affect the good purpose of the client satisfaction. Thank you.
Yes, I can say hand just behind Dr. Martin.
Yes.
And that should be the last.
Okay. I'm Stephen from the School of Public Health, Makerere. I have a question for Lucia concerning how she measured client satisfaction for women screened for cervical cancer. She had domains in the event of just satisfied, very satisfied. Was there a description of these domains for the clients to be able to respond correctly?
Thank you, and because of time, we've got to put the questions at that level. But allow me, before I call them to respond, to highlight something that's very cross-cutting. One, in leadership, there's a lot of accountability, and some of the quality issues we are buffering with at service delivery level are because of indiscipline and absenteeism, and you may not get quality where there is absenteeism in discipline. And this didn't come out. The component of leadership emphasizing accountability for results. I think across the board, that's just a comment. Then the second comment from me is I didn't see QI as being proactive. Proactive in the sense that even before the problem, there is a problem, there is a system, because as Martin has mentioned, this needs to be institutionalized. This is not the first framework. We are probably implementing the third QI framework, national QI framework, but we want to see that you were somewhere, and that makes it sustainable. DHO Quen, where did the other framework leave you? Did it now, after this, if this is an amplified effort, is it also going to collapse? What is put in place to make sure that these systems are sustainable? So I think with those remarks, allow me begin with, again, the elder, Dr. Nyeko, and the order, the way you presented, not the way you are seated. Dr. Nyeko will be followed by Ayub.
Thank you very much, Chair, and thank you, members, for those questions. I think they are very exciting. I had prayed
projective, yeah, sure.
I had prayed earlier that the chairman loses his watch so that we discuss a little longer, but I think that may not be possible. Let me begin with a general comment from Mr. Deke. The issue of I know it all. You found us here, you leave us here. I think that is a very serious concern that we should all open up our eyes at. Such group of people do exist, and they actually make work very difficult for those who are doing work in progress, work of implementing QI. We need to find a modality of helping such people also rotate. Maybe if they see how Lira does it differently, how maybe Fort Porto has it differently, they would be able to change their mind and appreciate the dynamics in service deliveries, that there is no one person who knows it all, who can do it all. They also will appreciate that the healthcare is not static, it's dynamic. Things keep changing day by day, and that will help us to also change with the changing system. So my appeal is to the Minister of Health that yes, we need to look into that. There was a proposal of recentralizing some cadres in health. I hope this is a work in progress, but we also need to implement the frequent rotation of health workers. There was a question specifically from Michael to me on the cow appraises the DHO. How do we involve cow in functionalizing the DICO? True, the cow is the immediate supervisor of the DHO. The discussion around that, I'll not go into it because there is a technical component and then there is a managerial administrative component that the cow has to deal with. The other medical component can be very difficult for him or her to supervise. This is where we would come in to help. The relation is not directly proportional, it's a bit indirect, and so we come in. How does the cow help us? The chief administrative officer is the accounting officer of the district. So all resources, including the human resource in there, is under his control. So for us to succeed, we must bring the chief administrative officer on board, appreciate the little that we intend to do, and support us morally and many times financially. In one of the presentations, the district is not allowing a budget for a certain facility to come on board unless they have component for QI.
Dr. Nyeko, we've got summarized.
Yes, and that is an indication that the cow has control and we need to bring them on board. Where they say yes, we're likely to succeed. Thank you.
Thank you, Dr. Nyeko. The rest of us, 2 minutes strictly. Ayub?
Thank you very much, Chair, and appreciation to the colleagues who have raised those concerns. I had quite a number of questions raised. The first one was asking, sorry, I didn't get the details of the persons asking.
No, go ahead if you got the questions.
So the first one was asking, how did we quantify the parameter? Okay, the denominator versus the numerators, and you find that okay, when we were implementing this, it was more of a qualitative assessment. That we look at the functionality of DICO. We had 10 parameters that would qualify a district QI team functional, among which we had things to do with the do you have members appointed, official appointed by the accounting officer? Do you have regular meetings? Do you have a QI framework? Do you have projects that you're implementing, including 5As, and then reporting to the relevant stakeholders? So the regional QI team was grading us on those parameters, and I remember there were 10 in numbers. So as we started, we had nothing. We didn't have any member appointed by the accounting officer who were not sitting regularly. We didn't have any QI project. So it was zero. As we went along, we started putting in place those key parameters that would qualify a team functional. So that is how we graded the district QI team. The same was applied to the health facilities, but now we changed to, if a health facility has all those parameters, they have the QI team, they are sitting regularly, they have the projects implementing, we take it as a unit. Then the denominator would be the total number of facilities that we had. in the district. This one answers question 4 that also came from one of the other people. There's another question that came as to why the graph was staggering. Did we implement all the test changes at the same time? The answer is no. We first started with capacity building. It brought us to some level. Then when it started staggering, we employed compulsion, adopting QI as one of the performance indicators for in-charges that would be assessed at the end of every quarter. So that one pushed us to another level. The second last was, I think this one was a general one, asking what worked best for all the projects that the various presenters have presented. You find that in Quen, what worked best was introduction of QI initiative as one of the performance indicators for in-charges. That one, it worked for us. And then my colleague from Mbale, they had money allocated, resources allocated to QI. It worked for them. Then there's another colleague who mentioned that rewarding best performers helped them to improve functionality of their QI structure. So you find that whereas we had one common goal of functionalizing these QI structures, we had different approaches, and those are some of the approaches that I managed to capture. Then from the chair, he asked, where did we start from and where did the other frameworks leave us? I want to mention that when I was presenting, I clearly indicated that at the district we were at 0. That one I admit. But we had something going on in the facility, courtesy of our implementing partners, majorly HIV and TB. Baylor had some facilities that it was supporting, which had at least some functional QI teams, and there was some semblance of quality improvement there. So that was our starting baseline. Thank you very much.
Thank you, Ayub. Proce, 2 minutes, please, if you can stick to that.
Thank you
Otherwise,
so much.
lunch is...
Thank you so much, Chair. I actually did not have a question addressed to me as a presenter, but there were 2 questions that were addressed to us in general. I want to respond to 2 of them. One was saying that staff that who claim have been on ground for a while, and so they are there to stay. How do we handle such case scenarios? I want to use the experience of Mbale district, whereby we have rewards and sanction committees at every levels, including the district level. We handle such members at facility level, and in case we've failed to handle fully, we can push them forward to the district level, which holds theirs every other month, but sometimes bi-monthly. But also, there is something that we are trying to test. We are calling it a counseling book, whereby in-charges, as a way of human resource management, they keep engaging individuals that are having challenges of having results at their facilities. Then the other question that was raised was health outcome results. Health outcome results was a very difficult measure for most of the indicators that are being tracked, since we had struggling structures at all levels. Now we started by streamlining quality improvement structures at all levels, including the work improvement teams that now are very equipped on what to do. So as Mbale district, in every quarterly performance review that we hold, we filter out struggling indicators, tag them to the focal program persons, TB, HIV, then they prioritize 2 indicators to open projects at district level for tracking. Then the innovations we have agreed on at a district performance review, we support facilities to still go down to their individual facilities, open up similar projects that are feeding to the district project, and in such a manner we are able to track performance in the indicators that are actually struggling in our district. That's what I'm able to share from Mbale District.
Thank you, Proce. Betty, 2 minutes.
Yes, 2 minutes, but I have a lot. Let me try.
Most of them are cross-cutting.
So the first one was about computer breakdown. How did we solve the problem? We set up a routine maintenance for this computer breakdown, and most of it was due to network problem, and it was slow network. Some computers were actually out of use, so the hospital managed to procure some new computers which were fast enough. For the slow network, we managed to set up many service points. This one also served for the long waiting time. There was concern about percentage, which concerns were very common. The common concerns of our patients was long waiting time. Long waiting time, which was attributed to the computer issues, and then few clinicians. But we were blessed that we employed more clinicians at these outpatients, and then the service areas were increased. Privacy for the clients during feedback. This one also comes together with issues of tagging names. Actually, in the beginning, we were not tagging names, and to the staff it was okay. When you come and you say, "You are rude," and then no one will think they are talking about them, and the rudeness continues. And at the same time, the ones who are not rude will not be happy. They will say, why are you generalizing? So it's a double-edged sword, because I'm not rude and you're saying all the staff are rude. So actually in our committee meeting, everyone agreed that instead of generalizing, why can't we ask these clients to mention names? And even despite of asking them to mention names, some of them were actually bold enough to say so and so, because some of these personalities were continuous, they were continuous. So by the fact that we tag names, for us as the Cho Hospital, we felt it was okay, because transparency is actually paramount. And if I know they will pin me out, next time I'll actually change. And then there was an issue of, the privacy part. We don't disclose, we don't ask these patients to tell us their names. And usually we have independent people who come to carry out this survey. Then there was issues of people who are not able to read and write. We have various modes of carrying out the surveys. Like I say, the on-site book is for those ones who can read and write. And then we have monthly surveys where someone comes and interact with these patients. We know most of our patients are actually unable to write. Majority of our patients, they come from hard to reach and they are not able to write. And then we have also quarterly survey that we do, and this one also caters for those ones who are not able to read and write. So there, everyone is actually catered for. There was an issue about cost of satisfaction surveys. For us, our satisfaction survey, we have not attached any cost to. Actually, when you tag cost to satisfaction survey, we tried and it was never successful.
I want you
people
to
come to do because they think there is money, but we deal with people who don't come to ask for money.
The rest they will ask you at the lunch break. Can I move to Lucia?
Thank you.
2 minutes. Lucia, 2 minutes. Then
Thank
Jeanette,
you.
2 minutes.
Thank you, moderator. I think I had about 3 to 4 questions. The very first question, how does the gentleman who asked connect the presentation to the title? He saw the title had improving client satisfaction, and then the title and then the presentation had findings. Majorly looking at if we had followed through, coming from the objectives of this particular presentation down to the recommendations, we're giving a highlight of key determinants of client satisfaction. And maybe just to highlight at the end, for some of the recommendations, I just want to reiterate, and probably for the rest of the recommendations, we'll have a detailed interaction. Some of the key determinants, and we also noticed key associations or correlations with client satisfaction, was making use of older women to inspire and encourage younger women is a very key determinant to improving client satisfaction. And then increasing awareness and availability of HPV vaccination gets to, and also health education on early cervical cancer screening, which was among the recommendations. Improving referral pathways for the different women with abnormal screening results, and also sustaining quality of care. That was from the recommendations, and it directly speaks to the title and from the findings that we had. Then the second question was majorly focusing on, were we able to interrogate clients from private clinics versus public facilities? No, we did not. Given that our sample size was majorly narrowed down to women living with HIV and have ever been screened for cervical cancer in the different facilities that we support. But this is key feedback, especially for consideration, given that we want to improve health care and access at all different levels and of care. The other was their description of the domains for clients to ascertain satisfaction. So yes, we had a thorough and detailed description, and the domains did not finally give a score of satisfaction. There was a separate question that was basically asking to what extent were you satisfied with the cervical cancer screening service. However, this was translated in Luganda. So the client would respond very satisfied, highly satisfied, etc. So that is the question that scored satisfaction with different rankings. The domains that we saw are the ones that kind of led a client to their final score, and also bringing to mind what their experience was like. We see that a client that responded, they were not satisfied, and one of the recommendation was not to tag refills to cervical cancer screening. Definitely at the end, also they were not satisfied, they would not recommend this, and some of what came to mind, or the reason they were not satisfied, is because these were tagged. So we had different questions that were finally leading to a final score, and some of them, as we got to see there, privacy, if a client didn't feel like the screening process was quite confidential, was the health worker empathetic, really questions around awareness, availability, health worker attitude, the environment. All these finally were leading to the last question and how they respond to it, on how they were satisfied with the service. Thank you.
Thank you. And our last respondent, Jeanette, and I think you have only one. Over to Jeanette.
Thank you so much. As a district of Lamour, there was formation of working groups, work improvement groups, which was formed at the district. So there are a number of areas that these groups were supposed to oversee: maternal, child health, we had TB, HIV, and quality improvement itself. So people were given responsibilities in small numbers, like 4, 5 in a group, to see that there is improvement in these areas. So as a district, why we came up with this innovation of improving participation of clinicians where because much as we have maternal, newborn, child, TB, HIV being implemented, that part of participation of clinicians in these areas was very low. That's why the district came up with this innovation, so that if we want to improve maternal child health, we want to improve TB, HIV, the quality improvement itself, the functionality and the participation has to first be improved. That is why we came up with this innovation, and as a district we chose this so that we improve on these other working areas like maternal, newborn, TB, HIV, and other functional areas at the health facility. I would also like to add on the questions which was asked about those staff who are not interested in performing quality improvement services. That for that staff in a district, like in my district, you give that staff an activity. You give a project for that staff to head so that they know and take initiative that if I don't implement or I don't make this project improve, I will be sanctioned or I will be punished. So we involve everybody, especially those ones who have the negative attitude that the change you are bringing is not going to maybe bring improvement. We involve them in those activities. We give them projects so that they learn and see that, oh, where I was going was not right. Let me move with the fellow colleagues and we improve on the quality improvement of the district and at facility level. Thank you.
Thank you so much, our dear participants. Let's put our hands together and thank this amazing team. You are now free to leave and have your lunch next to a piece of chicken for you and myself. For the rest of us, thank you so much for your comments. Thank you so much for your active participation. Is that hand for praying for us? There is no more hands. You look for the individual people and ask them questions. The meeting is officially resolved, and go for lunch because we are slightly behind schedule. The first group is already having lunch. Thank you so much, and have a blessed afternoon.
Yeah, let's give another round of applause to our session chair, Dr. Richard Mugahi, and also the panelists. Now, the arrangements for lunch, I know you already have the visas, the coupons for lunch. We have 2 restaurants here. There's Victoria Restaurant, which is just next from this side, and then there's also the resident bar. Don't worry about the word bar. So, because Musajja wa Kabaka can go to that one instead, but they're just serving lunch in the resident bar and the Victoria Restaurant. And after lunch, we shall be coming back here for the poster presentations for around 20 minutes, and then we shall go back to the breakaway sessions. So please, after lunch, let's convene. Just start off the poster presenters. Make sure you have an early lunch and you stand by your poster so that when delegates come, you are able to show them and explain what it's all about. Thank you, bon appetit, and see you at 3:45. Thank you. Just to alert the delegates, What we know, this place is very secure. However, it's also your responsibility to take care of your valuables. So please, if you have hard cash which you fail to keep, I can keep it for you. But please make sure that you also mind about your valuables, however much that the place is secure and everybody here is trustworthy. But mind about your valuables. Thank you.
Good afternoon. Can we have the poster presenters? Please make sure that you're standing by your posters so that we can use this chance to have a poster presentation. So colleagues, those of you who are back from the lunch break, kindly use this time to have a look at the work that is being showcased in the posters. We give it a few minutes before we resume our breakout sessions. So we call upon all those showcasing posters, please come to the hall and stand next to the poster so that you can be able to take people through the work that you're showcasing. So we invite you all to the poster session. Feel free to move to the poster of your choice, as well as ask as many questions as you may want. And we shall continue this later on after the breakout sessions. So people presenting posters, kindly come to the hall and guide the guests through the presentations.
Hello, good afternoon, good evening. Dear delegates, can I have your attention, please? According to the time check, we have come to the end of the poster presentations, and we need to go to the breakaway sessions so that we can start. May I call upon the session chairs and presenters to go to the respective halls. Here we are going to have Dr. Ronnie, who is going to chair the afternoon session. Dr. Ronnie Bahatungire, I hope you are around. We remain in Ziba, and then Dr. John Paul Bagala is going to Kama. So after the breakaway sessions, when we come back for tea, the poster presentation can continue because it's a marketplace. So the vendors, those are the presenters, can always come back at tea time so that we can continue meeting more and more delegates coming to understand the work they have been doing. So can we move? Conference Chair Dr. Agre, I need some assistance. I need to know the session chairs, whether they are around, so that I can hand over and we start. Dr. Alex, in the meantime, as I wait for the session chair, may I call upon the presenters in this hall, that is Ziba Hall. Mugenyi Geoffrey, at least by show of hands, please can you come and sit on this? Can I have John Paul Kakonyero? Where are you by show of hands? Please, can you come over? Michael Nanjubu. Michael Nanjubu. Where are you? Then May Namukwaya. May. And then Babile Lillian. Babilie Lillian. Babilie Lillian, may you please come forward? The poster presenters, Dr. Julius, just help me to tell the poster presenters we have ended the session now. They can resume at tea time. And the delegates who are going to stay here, please stay here for these presentations according to the program. In case you are interested in the presentation in Kama Hall, please proceed to Kama Hall. So you only to Secretariat, can you please contact Babilie Lillian just to find out where she is? Yeah, I want to announce the session chair for Ziba Hall is going to be Dr. Wangisi, the District Health Officer from Bale District. Dr. Wangisi, please come forward so that I hand over to you to proceed with this session. And in the meantime, those of you who are part of this breakaway session, can you please take up your seats? And in case you are still looking at the other posters, please do it quietly so that we can have the required silence for people in this breakaway session to be able to follow what is happening. Secretariat, can you please follow up with Babide Lillian? If at all she came and she's still maybe having lunch or somewhere, please try to raise her on phone so that she can come over. Thank you. So, this is the last call. Morongo Babidi is here. So, all the panelists for, and may I request just in any case, if presenters for Kama Hall are still stranded here, like Sarah Zarwango, Tino Mujini Muzafaru, Stephen Apol, Nagudi Frida, and Ivan Segawa. If you are still looking at the posters here, please, you are in the wrong place at this moment in time. Please proceed to Kama Hall where you are going to make your oral presentation. And now the session in Kama Hall is about to begin. Please, 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 let's observe what we have said. The poster presenters, please stop. I'm just requesting you humbly. We have ended. Dr. Martin, you can help me out. Members to end. The poster presentation will resume at evening tea. They will resume at evening tea. So the poster presenters, make sure that you come and you meet any of the other delegates who may still want to look at your posters. Remember, you are presenting for only one day, so we expect you to come back again to complete. So those of you who are going to participate in this breakaway session as per program, because each one of you has a program, please get seated. In case you are interested in the poster presentation, the oral presentation in Kama Hall, please proceed to Kama Hall. So good afternoon once again, ladies and gentlemen. Allow me at this moment in time to introduce to you the session chair for this afternoon evening, Dr. Wangusi, the District Health Officer, Mbale District, who's here to take us through this session. So Dr. Wangusi, you are most welcome. So you can greet your panelists. They are already seated here in front of you. And they're all yours. Thank you. Enjoy the session.
Yeah, thank you, Overall Chair. Good afternoon, ladies and gentlemen. My name is Dr. Jonathan Wangisi. I'm the District Health Officer for Mbale. It's a privilege to be standing before you. I've been requested to stand in for Dr. Ronald. I want to welcome you to this afternoon session on improved service delivery models. Friends, I want to assume that all those who want to be part of this session are seated. As you notice, we are supposed to have started at 3 o'clock. It is now 4 o'clock. So we are running 1 hour behind schedule. So we are going to cruise through. Fortunately, we have been helped by the absence of 2 presenters. We now have 3 out of 5. We have Dr. Mujenyi from Barara. Doctor, you're welcome. We have Kakanyero John Paul, and then we have Babire Lillian. Those are going to be our 3 presenters. I won't go into the titles of their presentation in the interest of time. As we did it before, we are going to be inviting the presenters and give them 10 minutes. We shall be flagging. You keep an eye on me because I'm going to be seated over there. And then after the 3 presentations, we shall usher them in front, and then we go into the question and answer. So without wasting much more time, I want to take this privilege to invite Dr. Mujenyi Godfrey to make his presentation. Let's put our hands together for Dr. Mujenyi. You're welcome.
Yes, good afternoon, ladies and gentlemen. I am Dr. Mujenyi Godfrey. I hope the IT is putting on the presentation. I come from Barara University of Science and Technology and Barara Regional Referral Hospital. I am a delegate of UHA Ankole. Thank you for sponsorship. And I'm here for respectful maternity care, and we are looking at how to integrate RMC into the healthcare system in Uganda. This work is done in collaboration with the SCAP department, the Reproductive and Infant Health Department of the Ministry of Health, World Health Organization Uganda, and of course UHA, and USAID FHI project. It's a work in progress. It started way back in April 2023, following a recognition. I hope the IT is sorting us. Is that okay? That's a different presentation. Sorry for that. So this work started in April following a realization of failure to achieve some of the goals in MNHC. And so we thought of integrating respectful maternity care into the Ministry of Health Quality of Care framework by innovating and forming the RMC or Respectful Maternity Care Integration Framework. Of course, the authors are people from the RMC landscape in Uganda. When you hear of RMC, you hear of things like, dignity, provision of care with confidentiality, free of mistreatment, informed consent. Basically care which is organized for and provided to all women in a manner that maintains their dignity, privacy and confidentiality. And this is what our dream would be when you go to a health facility. It ensures freedom from harm and mistreatment, enables informed choices and continuous, continuum of care, and it's achieved through effective communication between the sick person, the family member, and the community at large. And this care provided should basically be free from the 7 elements of the 7 negative elements, which include physical abuse, just a moment. The eyes are getting close to 50 years old, so some things keep changing. Mm-hmm. Yes, just a moment again. Just give me one more. That's better.
Yeah, as is trying to get the key points to reinforce the presentation, this is just an announcement. I want to let the delegates, I think some delegates think that there's another session in the Kama Hall. I'm not saying that you run away from here, but try to check the program and see whether you ought to be in the other Kama Hall so that you can also go and listen to those presentations. Thank you. Over to you.
Yes, care must be provided must be free from the 7 elements of physical abuse, non-consented care, non-confidential care, non-dignified care, including verbal abuse, discrimination, abandonment, and detention in a health facility for any reason. And we are aware that childbirth traditionally is, a social cultural event. Labor is associated with many complications, and health institutions must give a trade-off for desired care from what we want and what is traditional. Atkunda Esther et al. In 2020 found out that women still wish to deliver in a supportive, respectful, responsive environment that was loving. And women also say they should not only survive complications of labor, but also thrive and reach their full potential. And provision of RMC is a human right-based approach that reduces maternal morbidity and mortality. And in the background, we found out that there was absence of respectful maternity care, RMC, which contributed to the poor quality of care for women, newborns, children, and actually adolescents. There was no there was continued disrespect and abuse during provision of this pregnancy-related care in Uganda, and the World Health Organization, in collaboration with partners, has developed MNC quality of care, standards encompassing the provision of experience of care, comprising of 8 domains of care, which many people know. And again, we found out that Uganda's maternal mortality rate remains high despite recent significant drops, because every mother that dies is a statistic, and we don't want anybody to be the number. Even if it reduced to 10, the 10 who die really stay the number and not the statistics. Thousands of women and newborns still die, and 17.2% are teenagers who are between 15 and 19 years old. These are young mothers with a full potential ahead of them. 95% of women, including adolescents, attend at least an antenatal care, but only 10% still, and 10% still deliver at home, which means that there's something that they are running away from our hospitals. That's 8 domains of maternal and newborn quality of care framework, where Uganda has done quite tremendously. Of course, first adopted it. They made strides in standards 1 and 2 and 3, which are health systems. Then experience of care, which is standard 4, 5, and 6. They perform poorly up to now. And these are the reasons. 90.9% of women are encouraged to adopt position of their choice during labor, and not only 10% in Uganda are asked a position of choice at birth. The rest we dictate. Lie on this flat couch, hold your head like this, without their participation. Only 38% of health facilities had a system in place to ensure all women are received and treated with respect and dignity. Only 27% of the health facilities were rated as having good practices of providing age-appropriate messages tailored to local needs for women, and about 54% of the health facilities were rated in their need for improvement. And this was a review in 30 districts, I think, by UHA in 2023. We went ahead to look at the local evidence. What is the document review? There were actually several stakeholders influencing RMC practice in Uganda for the last 5 to 10 years. But on the other contrary, all these stakeholders ended up with the reports, bulletins, policy briefs, and we found out that nothing peer-reviewed was documented in the journals. Other countries had some documentations, but in Uganda, we found ourselves with nothing. And then RMC services would be delivered within the 8 WHO domains, which is an opportunity that is available for us. And I won't go into these standards because this is QI, I'm sure you know them. And we went ahead to find out the state of affairs in Uganda. There was no RMC roadmap, and there was a consultative meeting in April 2023. An RMC working technical steering committee was set up that encompassed the relevant people. There was hiring of an RMC consultant, a job which I took, and charged with the responsibility of developing an RMC intervention framework and the training manual. The overall objective was for the SCAP and RH department supported by FHI to really come up with the roadmap for RMC. We used the fishbone methodology to identify the root causes of disrespect and abuse of women, and for each identified gap, we coined a suitable recommendation, and information generated from this process was used to integrate RMC into RMNCAH quality of care in Uganda, and subsequently developed a framework and a manual to guide domestication of RMC in Uganda. And that's the fishbone methodology pictorial, where we found a lack of RMC-oriented healthcare services in Uganda. And we looked at the bottlenecks at the national level. We identified national level gaps, district level gaps, health facility gaps, and community gaps. What were the results generally? There were around 8 common causes of mistreatment, which included lack of RMC intervention framework and RMC manual to guide practice. And there was no approved charter or policy documents to guide practice. There was inadequate human resource for health, poor RMC-oriented governance and leadership, inadequate infrastructure and funding for RMC, lack of media engagement. There was lack of RMC knowledge among health unit management committees, lack of water, hand wash facilities, and adequate space for toilets and bathrooms in the facilities. And so, what are the conclusions of the lessons learned? And of course, the steps taken. We thought it is important to integrate RMC into MNH quality of care framework, and this will empower healthcare workers and health facilities to deliver quality RMC services to women and newborns with dignity. And I'll just ask for an extra minute or a minute and a half. What's done so far? RMC intervention framework and its monitoring and evaluation framework have been developed. They have been validated and approved by the RMNCAH Technical Working Group for the Ministry of Health, and they are at the level of approval. And once these documents, including the training manual, are approved, then they will be considered for use in the guiding practice in everyday life. Little snapshot on the framework. The goal is to ensure all women, including adolescents and newborns, receive dignified, respectful, high-quality care during pregnancy, labor, and postpartum period to improve health outcomes in Uganda. It has 4 strategic goals: to provide guidance on strengthening health systems at all levels, to integrate or domesticate RMC into healthcare services in Uganda, to strengthen the knowledge and skills of all healthcare providers, provide RMC-oriented services, pre and in service, to improve the capacity for all healthcare facilities to provide RMC integrated services, and to create awareness or empowerment of the community members to demand RMC services. The intervention framework is in place. It's structured like that. The stakeholders are all outlined in there with their roles, and it is available if you need a copy to make any input, because it is not yet approved. And I acknowledge the SCAP department of the Ministry of Health, of course the Reproductive Health and Infant Child Health Department, USAID, FHI for funding this work, and UHF for sponsoring me to come and share this with you. I thank you and bless you.
Yeah, that was Dr. Mjenyi. Please let's put our hands together and appreciate him a little better. Thank you for the wonderful work you're doing. Actually, we look forward to its scale up. Ladies and gentlemen, our next presenter is going to be sharing with us on the usage of VSTEC CD4 lateral flow assay, semi-quantitative test to improve on advanced HIV disease management in the Bidibidi refugee settlement, Yumbe districts. Please put your hands together and welcome John Paul Kakanyero. John, you're welcome. 10 minutes, please.
Thank you so much. My name is Kakanyero John Paul. I work for International Rescue Committee in Bidibidi Refugee Settlement. I am a medical laboratory assistant. That's mean I hold certificate in medical lab. However, I'm also a diploma student at the moment. I need to acknowledge my co-authors and other colleagues, other affiliations, organizations. Today we are going to discuss about the usage of VSTEC CD4 lateral flow assay semi-quantitative test to improve on advanced HIV disease management at Bidibidi Refugee Settlement. Yeah, Bidibidi Refugee Settlement is the biggest refugee settlement in Uganda and in Africa, and is the second largest refugee settlement in the world. It is located in Yumbe district, West Nile, northern Uganda. The next, this other one, photo there, that is the aerial view of the refugee camp. Now, you find in sub-Saharan Africa, that Uganda is inclusive of it, you find a third of people who are starting ARV treatment, or the clients who have left care because of one or two reasons. Most time presents with advanced disease, and they are really at high risk of mortality. So we have this strip you can see at the corner there that we use. Now, this strip is the same like normal rapid kit we have in our facilities. The normal kit are qualitative. It tells us whether it is positive or is negative. However, this one is semi-quantitative. It tells us whether the CD4 is above 200 or below 200. Now, for us, we focus on using these particular test kits to improve on advanced HIV disease in health facilities offering art services in Bidibidi Refugee Settlement in Yumbe District. Now, what we use a cross-sectional study design where we reviewed the CD4 test that we have done on people living with HIV, targeting all health facilities that are offering art services in Bidibidi Settlement. We target, while we are targeting people who are starting treatment or already on care, and we did this project for a period of 5 quarters, that is 1 year and 3 months. And the key intervention that we put in place was, one, we mentored facility staffs that include laboratory team, art team, clinicians, the counselors. After mentoring them on how to use these test kits, we also distributed these test kits using the hub system with support from IDI. IDI is the one leading us in covering hub system in West Nile. Then we had periodic support supervision that was well facilitated by IDI. This one was not only implemented in Bidibidi Refugee Settlement, it was implemented in the whole district. However, I was overseeing Bidibidi Refugee Settlement. And now, afterward, we analyzed the data 2 quarters before the interventions, 2 quarters after the interventions. Then we presented it into a graphical manner that we shall see in the results. Here is this other first photo. That is me when I was doing on-site mentorship in one of the facility in Zone 3. And this other one is when I was doing technical support supervision and follow-up in the Bangatwitel Center 3 in Zone 4 in BDB Refugee Settlement in Yumbe District. Now, if you are to see, the 60 and the 75% was before we introduced the strip into the system, and the 92 and the 96% is when we introduced the strip into the system. The 85% was when there was stock out of this strip. However, as I talk right now, I'm very happy that all the facility has the strip, and we at 87% as I talk of now, with the goal of us reaching 100%. This next graph tells us out of 100 people that we tested, 77.2% had CD4 above 200. Meanwhile, 22.8% had CD4 below 200. And these are people having advanced HIV disease. Now, we registered a very great improvement from 60% to 96% on CD4 uptake within the BDB refugee settlement. And also at that time, we tested 561 clients, their CD4 using the strip. Out of that, 128, which makes around 22.8%, having CD4 below 200, and 433, which makes 77.2, had CD4 above 200. Now, what, of course, the target, as you're quite aware, HIV does not kill. However, it works on your immune system. Now, after working on your immune system, the opportunistic diseases come and knock you down. So, the leading cause of death among HIV clients is TB and meningitis. So, those people who had CD4 below 200, we tested them for TB LAM and serum crack, and they were managed appropriately. Now, the lesson we learned is this particular strip here, it is really very, very good for early detections of advanced HIV disease, being it is very simple to use and it's a user-friendly technology. Apart from that, when the uptake of CD4 strip is considered, you realize that it helps in timely interventions and it enhances overall improvement of advanced HIV disease management among people living with HIV in the resource-limited environment, which talks about it is covered a bit in our theme of today. Now, in our conclusion, we realized that this using this strip did not only improve on the testing of CD4 alone, however, it also improved on the uptake of TB LAM tests and also serum crack tests. Now, apart from that, we realized that this CD4 test kits is really very good, and it can really help for decentralizations of CD4 screening in the resource-limited environment, especially in health centers that do not have access to CD4 machine. You find out that most health center 3 and health center 2, they don't have the CD4 testing machine. However, this strip can be distributed to them, and it can really help them to improve on advanced HIV disease. Besides that, we realized that this particular strip, it really prompts on the management of advanced HIV disease at lower health facilities. Now, our key recommendations are the Ministry of Health and implementing partner should organize for trainings and mentorships for health workers to improve on the decentralizations of these test kits, if possible, countrywide in the actually lower facilities. Apart from that, we need to involve the lay health cadres. When I say lay health cadres, I mean the nurses, the counselors, those who are not technical enough in the part of diagnosing, actually the laboratory people, so that they can use these test kits in lower health facilities. I need to acknowledge key people. One, International Rescue Committee that I worked for, particularly Dr. Patience. I know she's online following me right now. We acknowledge your effort. We also need to acknowledge UNHCR, our donor at the moment. We have other donors, but UNHCR is the biggest donor at the moment. We also need to acknowledge Yumbe District Local Government, our QI focal persons within ASEA. They have really done a lot of work as far as QI is concerned in Yumbe, including the regional QI team. I also need to acknowledge the Ministry of Health. They are doing a lot of great work. I also need to acknowledge IDI. There is Madam Salama and Dr. Nelson. They really did a lot of work as far as this project is concerned. Then lastly, I need to acknowledge Uganda Medical Laboratory Technology Associations. That is the association that I subscribe for. Thank you so much. In case of any questions, I'll be available. Thank you.
Thank you. Thank you, Paul. Friends, a bigger round of applause for John Paul. Thank you for sharing the experience of Yumbe District. Now, last but not least, ladies and gentlemen, we are going to hear from Babiri Lilian. She is going to share with us her experience on improving resource mobilization in civil society organizations through capacity building interventions in Uganda. Lilian, you're most welcome, and you're good to go.
Thank you, Chair. Good afternoon, ladies and gentlemen. My name is Lilian Babilye. I work with the Infectious Diseases Institute in Makerere. This afternoon, I'm going to share about improving resource mobilization in civil society organizations through capacity improvement interventions in Uganda under the theme of health financing. I acknowledge my co-authors. In sub-Saharan Africa, up to 20% of health spending is allocated to HIV services, with over 85% of the funding come through international donors. This is not different in Uganda, with only 3% of the GDP allocated to HIV services for at-risk populations. In October 2020, after the implementation of the Key Population Investment Fund project under IDI, we found that 10% of the civil society organizations had funding to continue with implementation of HIV services, and the rest could not sustain the project interventions because they did not have any funding to continue with implementation. To improve resource mobilization at the civil society organizations, PEPFAR through CDC supported IDI in resource mobilization capacity building interventions for civil society organization staff through training and post-training mentorships. How this was done, between November 2020 and December 2022, our team conducted resource mobilization trainings for 134 CS4 staff from 62 civil society organizations in 11 regions in the country. These trainings focused on development of resource mobilization strategies, development of organization income generating activities, resource mobilization plans, proposal writing, and among others. Quarterly post-training mentorships were conducted by the team to offer additional support to CSOs in areas where they are still challenged and support them in development of some of the proposals that they are working on. Data on proposal submissions, this is after 6 months post the training. An assessment was conducted and the data was entered in ODK, Open Data Kit, on number of proposals that the CSOs had submitted and the number of proposals that were awarded. And we also picked qualitative data to back up this information. The data was analyzed in Excel, where we looked at percentages of the proposal success rates for each of the CSOs in randomly selected CSOs that were 35 from the 5 PIFA regions. So we found out that 5 civil society organizations had achieved a proposal success rate above 49%. Those are the ones highlighted in green. And a few of them were still struggling after the training that had below 15% proposal success rate. Overall, 524 proposals were submitted by the 35 civil society organizations, and of these, 36% were successful. The 5 CSOs that scored above 49% are those highlighted, and we also found out that there was a 4% increase in the number of CSOs funded by more than one donor. As seen from the introduction, majority of the CSO initially had only one donor, but after this training, we saw that there was that 4% increase of those that had more than one donor funding the HIV services. Resource mobilization trainings improved proposal outcomes from 10% to 36% in 2022. However, trainings without post-training mentorship limits the performance. And CSO staff were trained, but we also found that some CSOs are still struggling, and those scored 20% below the success rate. There is still need to support CSOs in donor mapping and linking them to donors, because these are mainly the areas that they are struggling with. We learned that the trainings in resource mobilizations improve civil society's ability to apply for and get funding for their activities. And investments in resource mobilization play a vital role in ensuring continuous flow of resources for sustainable community-level programming focused on key populations. That link is just someone sharing with us some of the lessons learned, and these people that had the highest proposal success rate, so they were sharing with us their success and what they've learned from the trainings. In conclusion, different CSOs will need different interventions based on their strengths and weaknesses, and poorly performing CSOs should be supported through startup of quality improvement approaches. We asked that the implementing partners should offer tailored resource mobilization trainings and continuous mentorships to indigenous civil society organizations to be able to improve resource mobilization. And to the CSOs, we request that should develop and monitor the resource mobilization strategies, focusing on resource mobilization planning, donor mapping, assigning responsibilities, and setting targets. And lastly, to the implementing partners, and the IDI CSO mechanism should support CSOs in donor mapping and proposal writing. I want to acknowledge our funders, CDC, PEPFAR, and Infectious Diseases Institute. Thank you.
Yeah, thank you so much. Members, I think she deserves a louder round of applause, Lillian. I think, Lillian, you can stay in front and maybe step in front there as I invite the other team members. Ladies and gentlemen, we've come to the end of the presentations. We've had this evening 3 presentations. The first was from Dr. Mujenyi. You saw the RMC model or framework that they piloted in Mbarara. Dr. Mujenyi and Paul, you can come forward, please. Then we also saw from John Paul the experience of using the CD4 lateral flow to detect advanced HIV disease in Yumbe. And you've just seen from Lillian the ability of implementing partners to support our civil society organizations to be able to live and sustain their programs beyond the projects that have been supporting them. So I'm sure you've been taking notes. I'm going to ask somebody to come and volunteer to move the mic. Okay, my sister over there. So it's now question or comment time. But because we are many, we shall limit to 1 or 2 questions, a question and a comment, so that we involve as many people as we are here to hear from as many people. So we can start to 1, 2, 3, 4, 5. Let's first take these 5. Okay. Number 1. You skipped number 1. Number 1 is here. Okay. Let's start. Number 1, let's start from here. 1, then 2, 3, 4, 5. Then I'll move over to this side. Yeah, you pose a question and direct it to the, be specific, please.
Thank you very much, our presenters, for this session. My name is Kasada. My question goes to the presenter of this quick CD4 lateral flow technique.
Yes.
Thank you for the presentation and bringing it to our attention. You know, Uganda is among the low, is among resource-limited countries. So we were wondering if this intervention is really effective, like how we have seen, and there are strategies to scale up to other districts and the lower health facilities, because we see it can deliver great impact within our community. Thank you.
Thank you. Number 2, over the other side. Yes, the 2 ladies are 2 and 3.
Yeah, thank you so much. My name is Irene Nachilija, and my question goes to Dr. Mujenyi, just to thank him for championing dignified care to mothers and their children. The key thing is that we needed to know the characteristics of the 27.3% of the health facilities that were providing good, the respective maternal and child practices. We needed to know, are they BMOC facilities? Are they CMOC facilities? Could they be government? We needed to know more about these facilities. Then the other, we've seen a lot of efforts in having this respective full maternal care into the in-service practice. How is the experience on the pre-service training to health service providers? Thank you.
Okay, number 3, your neighbor.
Good afternoon, ladies and gentlemen. My name is Joanna Kazi. I work for AMREF Health Africa on the Heroes for Gender Transformative Action Program. I would like to thank the presenters this day, and more so Dr. Mujenyi for the RMC framework. I just have 2, 3 things to put across. One is, as he presented, there was a statistic, I think on the first slide, right after quoting maternal mortality ratio. There is something about young people
teenage,
that I think had either from UNICEF. So was it age group that 10 to 24? But he read it as a year of 10, 24. I'm just seeking clarity. If you could look at his slides. 2, there is something that was mentioned on this has been approved for use, but I'm just requested to know what is being done to cascade this to lower level facilities outside those that were it was piloted. And then lastly, is this initiative focusing on only public facilities and not the privates? And what is being done to integrate now that it's been integrated in routine services? Are we looking at only private? Are we looking at only public, or both? And what is in progress regarding that? Thank you.
Okay, number 4. Number 4. And then 5, then we cross over.
Thank you. My name is Ronald Mangeni, and I work with Baylor. My question goes to John Paul on Visitect Uptech. One, you know that there's been reported challenges on interpretation of results for that kit, which is highly dependent on the strength, color of the test bars. So the question is, have you participated in any quality assessment scheme to ensure that the results provided are accurate? Thank you.
Okay, that's a good one. Number 5.
My name is Kamugisha Peterson. Thank you very much, all the presenters. I want to specifically go to Mr. John Paul. I thank you so much for matching today's theme of innovation. I want to just find out whether this is your innovation or it is a supported innovation from somewhere. You kept on saying, I did this. So I wanted to feel motivated whether I could also do the same thing. Then lastly, maybe since this is a new finding to some of us, you could also share with us about how reliable or how effective it has been found, such that we could say every result that comes out of it is true. We don't need to conduct another test or something of the sort. Then maybe another small thing is, does the ministry and the department concerned know of this innovation? Thank you so much.
Okay, thank you. So, okay, let's have him, then we cross over. Just keep noting, Doctor, the team, the presenters. We just want to wrap up the questions and then we go into your feedback.
Yeah, thank you. I'm called Edgar Tusubira. My question goes to Honorable Lydian, who presented about resource mobilization for the civil society organizations. I saw that in some instances, the failure rate for those that submitted proposals was actually a little bit higher. Could the factors be related to the capacity built within those, or there could be other confounding factors? Thank you.
Okay, let's see, by show of hands, the people willing to, 1, 2, 3, 4, 5. Okay, let's take from number 1, 2, 3, 4, 5. And then I think that is a fair sample.
Thank you, all the presenters. My question or comment goes to Lilian. I'm Gordon, I work with GSCRC. And thank you for supporting the civil society organization to get resources. As part of your post-training mentorship, I was wondering if you have been actively engaging, one, in identifying possible funding sources in terms of RFS for these CSOs. 2, if you have actively supported them in the review and submission of their proposals. Thank you.
Okay. Number 2 on this line is your neighbor there.
Thank you. I'm called Justin Komakech. I work for LPHS Lango. Yeah, I'm asking for the case of BDBD. Paul. You are testing approaches, community versus facility, and how were you able to reach, especially the non-suppressed clients who may receive their first IAC from the community with those ones with viremia, but also your approach at the facility laboratory testing versus point of care testing, like by the counselors at the counseling room. And then your challenges, why you were not able to reach 100%, especially along the way. Where did you encounter challenges, then mitigation measures if available? Thank you.
Okay, your neighbor, number 3.
Thank you so much. I am Magoa Lilian. I work with Lira District Local Government. My concern goes to my brother who presented on the Visitech. Of the numbers that you gave us that you reached so far, I would like to know of those ones were children also among. Thank you.
Okay, thank you for being brief. Number 4. That gentleman, the number 5. You're actually bypassing him near the camera. Oh, there.
Thank you, Chair. My question goes to the presenter, Visitech, the CD4LFA. My concern is on the issue of the source of this equipment. To you, it looks like you were actually the source, and the facilities receive them from you. So, you know, my worry is always you IPs, you put sometimes these innovations above our bar. Above the bar, to the extent that even
please
our
be
mother, the
precise.
Minister of Health,
Be precise. Above the bar.
cannot reach it. So,
be precise so that
tell us the direct source of this tool or equipment.
Okay, thank you. Number 5. Number 5, just around here. Yes, I think that is our final Q&A.
Yeah, this is the final one. My name is Francis. I work with Chai Uganda. My question goes to Lilian, the CSO. It's related to what someone asked about the RFAs. I was wondering, in your the mentorships or follow-ups, if you support the CSOs to co-fundraise, since some of these CSOs actually have similar interests, so to avoid issues of duplication. And then the other thing is on whether you have mechanisms for accountability, because some of these CSOs are under the umbrella of not-for-profit, but actually the individuals, the interest is more of money-making. So if they put these resources into the right use. Thank you.
Okay, thank you. Please come over. Dr. Mujenyi has a question, much as he was
I have a microphone here.
Where?
Can I use it?
Where?
Here.
Oh, you have? Okay. Sorry. But Doctor, you go ahead, please.
Yes, I also have
a
question to my neighbor, Lilian.
Yes. Please go ahead.
Yeah, I'm asking, not as a presenter, I'm asking as an academician here. We have realized with a lot of concern that many implementing partners spend a lot of funds, and the funds are spent, the period is gone, but the evidence is not documented. And the documents that we are talking about are peer-reviewed publications, which will last a long time. We see a lot of bulletins and reports, closure kind of agreements, but when you come later on to review the evidence of what happened, and I had an experience with this respectful maternity care. I found White Ribbon Alliance was here. A lot of projects had done work in Uganda, but you go in the literature, you search and search and search and come up with nothing on RMC in Uganda. So to what extent are you prepared to partner with at least the academicians? These long-term projects should have attachment with the universities, with the master's training, with PhD scholarships, so that these students become the foot soldiers and they document evidence on behalf of the money holders so that we do not look as if we are not an academic-led community. I ask you for a comment. Thank you.
Okay, maybe before they can respond, let me field two questions. Paul, you really showed us about the VSTEC and its ability to pick advanced disease. And you said that led you to the TB LAM and the serum CRAG. But because you are linking that to advanced HIV disease management, you did not show us of those, what was the numbers of TB LAMs and the serum CRAGs that besides the differentiation, how many the TB LAMs and TB and serum CRAGs were conducted? And then to Lillian, somebody has talked about the fatality rate. I wouldn't say very high, but of course, I'll look at your intervention impacted. But I would want to know, for those that failed, what additional support have you been able to provide to these CSOs that, and maybe what could have been the underlying issues that affected their competitiveness during the RFS? So back to you people. I will start with Dr. Mujenyi.
Yes, thank you for once again giving me an opportunity to share. I want to make it clear that the goal of the RMC intervention framework is to purpose it to be integrated into routine practice in the healthcare system, reaching 90% of healthcare workers in 90% of BMOC facilities and CMOC facilities by 2025. If at all we are lucky, the ministry takes it up. In 2-3 years, we hope 90% of healthcare workers in 90% of the public health facilities. I am bringing out this to answer the question of saying, is this RMC thing a private or a government facility thing? We actually noted that in private facilities, there is a little bit of respectful maternity care. They call it a little bit of customer care because there is an exchange of money. And if you do not hold me very nicely, in a respectful way, I will take money to the next shop because it's my choice. So this thing we are talking about is not an assessment of private facilities. It is an assessment of government facilities. The BMOC and CMOC sites in our country, the National Referral Hospital, Kawempe, you know, the regional referral hospitals, or the 14 were assessed. No, some of them, because the assessment was in 30 health facilities in the whole country. And so it's not a private thing. This is what is happening. Some of the facilities are actually doing well. From the assessment, we thought we would have got, you know, nothing, but most of the facilities have at least a starting point. So you asked, Irene asked about the characteristic of the 27% of facilities. The reports are available. They are very big. If you want a connection to the reports, we can avail them for you. But some of these facilities, like 25%, 27%, had something to show off. Of course, 54% had more or less lacking elsewhere. RMC services for in-service, the people who are in service, because of the experiences of training here and there, they have at least something to offer. But we are visibly not teaching this to our nursing, midwifery, nursing schools, medical schools. So in this intervention framework, there is a very big component for pre-service to integrate it in the curriculum, and then finding out the partners who are engaging the training facilities, and at the same time, engaging those ones who are already in service. So it's comprehensive. Someone asked about the statistic of 17.2%. It's the contribution of maternal death. 17.2% of the maternal deaths we are occurring in Uganda are occurring in young people who are aged between 15 and 19%. It looks as if it is an average of the age bracket. But no, 17% of maternal deaths were contributed to by women who were 15 to 19 years. And these are people who are actually not supposed to be in the labor suite. So it means that we are offering them delivery services instead of offering them other services elsewhere, like education and empowerment and things like that. So there is a lot that needs to be done. I think basically those are the areas that were asked about, but I'm available for further discussion along the way. Thank you.
Thank you. A big round of applause again for Dr. Mjenyi. John Paul.
Yeah, thank you everyone. I am really very impressed because I think a few of you, it is their first time to hear about this test kit, and after answering some of these questions, we shall, I think, be at the same table. I want to start with the big man that I didn't indicate the number of TB-LAM or serum crack done. I think I should. If you see in the second, the second graph in the results, it says that we had around 128 clients with CD4 less than 200, and all those people we did TB-LAM and serum crack for them. And I even further said that they were all properly managed. Okay. The second thing was about, which I really brought issue, is about the quality. Yes, I am a laboratory patient. I take quality seriously. So what did we do to ensure that these test kits are of quality? We have CD4 testing machines within Yumbe district. And before we even use the strip, we had to do internal quality control. And how did we do that? We tested the CD4 using the machine versus the CD4 using the strip, and we realized that it was working well. And before it being introduced in the system, it was done quality control and it has passed, quality assurance, and it has passed by the manufacturers. This woman bring me now to where is the source of this test kit. Yes, this test kit has been introduced by Ministry of Health. The first supply we got was from Central Public Health Laboratory. Currently we are getting it from National Medical Stores. Then this one brings me to a question that how can it reach other facilities? As long as you are in a government facility, please make your order via National Medical Stores, then you have it available. In case using it is a challenge, please, you either read the leaflets, or I can even give you my number, you call me and explain for you in detail how it is used. This one also brings me to another question that I was more talking about. I received these strips were from myself. No, I think the strips are not from me. And if I said most of the thing was maybe I was concentrating on how the implementation was, the strategies, because sincerely in BDP refugee settlement, I was taking charge and ensure that I mentored those teams. I ensure that the strip reaches everyone, and I followed through support supervision that everyone is using to improve on advanced HIV disease management in BDP refugee settlement. However, the district level focal persons and the HAP coordinator, they concentrated on other health facilities that are not within BDP refugee settlement.
Paul, are you done with the questions? Because our time is running.
Okay, just, my questions were kind of many.
Okay, it's okay. But just
then, to summarize, a colleague asked what were the challenges that we faced. Yes, we faced, actually they stocked out of the strip. There was a breakup when CPHS supplied. The National Medical Stores had not yet started supplying, so we had stock out. That's why, if you see in our graph, there was a reduction in the percentage, and currently, as I talked, we have improved. There was also questions on if children were captured. Yes, children were captured. However, children below 5 years are not, they don't use this particular strip, but a child of 6 years and above, yes, we captured them as long as they are the targeted team to work on. Then someone also asked whether this was very effective because it is you use your eyes to interpret. If you see currently in lower facilities, most of the tests are visibly interpreted. You mean you use our eyes, especially the malaria RDT. If it now says we don't use this strip, that means we should even stop testing malaria using MRDT. So this strip, as long as you follow the SOP, it is really very, very good. And I request that if the whole country can take it up, especially those in lower facilities without this strip, please, it can work very, very well. Thank you so much.
Okay, thank you. Thank you, Paul. And then over to Lydian for your feedback.
Thank you, everyone, for the questions and the comments. There was a question on the CSOs that did not have a high proposal success rate. We had 8 CSOs that registered below 10%, 10% and below proposal success rate. And for these ones, the major issues were around their resource mobilization strategies. We looked at the resource mobilization strategies, but they were not good enough. They had not, for example, they had not assigned responsible people to do the resource mobilization, and no one was accountable for this task, and also donor mapping was a challenge. So we've supported this. We continue to support them by ensuring that we share RFAs. We have a WhatsApp platform with all civil society organizations in the country. So we share these RFAs through that platform, but also on the emailing list. We've also started using coaches. These are CSO staff who are good in proposal writing, who have supported their organizations well, to train other CSOs and support them in identified gaps. Doctor had a question on whether we are involving the academician to document our work. At Infectious Diseases Institute, we are under the Makerere University. We closely work with academicians, and we work with different fellows, scholars, to be able to publish our work and also document the interventions. But we take note of that, Doctor. The other question, I think the other question was related to the proposal success rate. And post-training mentorships. So we support them in post-training mentorships. And when we realized that we had some that are not yet to task, especially those that did not achieve above the 20% proposal success rate, we've identified a team, a TOT team, that is going to support the CSOs in the reviews of these proposals before submission. That's it from the question.
Okay, let's appreciate Lillian. Thank you. Ladies and gentlemen, on behalf of the conference secretariat, I want us to once again give a big round of applause to our presenters this evening for a job well done. And thank you so much for being a good audience. I just want to end this session at that. Thank you so much. God bless you.
Yeah, you can remain seated because we need to appreciate this team. You see, presenting in the afternoon, after lunch, usually is very hard. But let's join our hands to applaud this team, who have, especially Dr. Wangusa, who has ably accepted to chair this session. A big hand clap for him. And then for the panelists, JP, Dr. Godfrey, and I heard they called her Honorable Babili. One of the person who said Honorable. I don't know, maybe she's a Honorable, we didn't know.
MP to be.
Yeah, MP to be. Yeah. So thank you so much for that. Now, as you're fearing the hot seat. No, you can enjoy the hot seat, so it's no longer hot. You can just mute the mics. Now, just a few administrative briefs. First and foremost, I want, may I request, I want the organizing team just to stand up and clap for these colleagues, for the delegates. Let's appreciate the delegates because they have been awesome and they have really participated up to this time. Yeah, we have come to the end of day one, and we have tea. However, I know we had limited time for the poster presentations, so I'll request the people who are presenting the posters can come. As people go for tea, you can continue the posters because we have some posters at the tea area as well as in this auditorium. That's one. Two, tomorrow we are beginning at 9. Whether we are 2 or 3, as long as we have the session chairs, we are beginning at 9. We have a very important keynote address of Professor Handa Yujiro, who is from JICA. I'm not sure whether he has flown in or he'll be online. So he's already in. So what I know with the Japanese, they are very time conscious. So let's do the needful, be here by 9. We start off with that presentation from him with a keynote address. And we have another one also, another presentation which will be exciting by Dr. Esther Karamaji Nkoro from USID for that morning session. And then we shall have the discussions and the break. So we shall have different breakaway sessions still as per program. And of course, the secretariat is going to work very hard to make sure that the presenters are notified once again, reminded, so that they're here in time, so that we have a joyful day 2. Let's appreciate the IT team. They have done us well, at least when you're on the mic and you don't have to strain your voice, so let's give them a hand clap. And also a hand clap to the hotel, in spite of the hiccups in the morning over Yaka, because at least they have managed our nutritional requirements and we have managed the day well. So we hope those things don't happen again. So God bless you. Let's go for tea. And those of you who would want photo shots on this banner, you are free. You come and take selfies because they will be needed for accountability. Whoever sponsored you to this conference. So thank you so much. Let's enjoy the tea. Yeah. And the conference chair and the organizers, we shall have a small brief meeting just to recap of what has happened and then to plan for tomorrow better. Thank you. The poster presentation, the presenters can be around, and so that members, when they come, they are able to, you are able to explain to them and the like. In case you have any challenge, lost and found, you missed something, please let the secretariat know so that we can address your concern. Otherwise, we expect you to be in this place and stay well, healthy, and safe. Entebbe is a good